Good morning, everyone.
Good morning.
Good morning, Mike. Sunny. It took me a minute to find you here.
Hi, Sunny. This is quite a large group we got assembled here.
Mm-hmm.
Good morning. Can everyone hear me?
Good morning.
Hey, Michelle.
Hi.
So before we get started, I just wanted to do a sound check for all the board members. Can all the board members say hello to Michelle?
Hello.
Good.
Hi, this is Robin.
Hello.
Hi, Michelle. This is Tom.
Perfect.
Hey, this
Okay.
is Dave Merman.
Sounds good.
Great.
And then do you want or do you know the speakers for the hospital today?
Yeah. Good morning, Sunny. How are you?
I'm well. Thank you, Owen.
Good, good. Hope you're feeling better. Last time we spoke, you were a little under the weather.
Thank you. Thank you for asking.
Yeah, so I believe, did we provide you, Michelle, a list of the witnesses for UVM?
Yes, you did. I have 9
Great.
speakers possibly. Is that right?
Yep. And Sunny, is
Okay.
that still correct?
I believe that is accurate. That's the potential number. Yeah.
Okay.
And Michelle, we haven't met. I'm Sunny, but if you want to run through that list and everyone will make sure that they're working, if that's what you want, we're happy to do that.
Okay, I can do that. I have Steve Leffler, Judy.
Good morning, everyone.
Okay.
So, I'm sorry.
That
Good morning,
sounded
everyone.
good. No, that was perfect. Sorry, I didn't know I was gonna get answered, so I can pause. I'm just trying to see the faces at the same time.
Michelle, I thought we just wanted to make sure that everyone's audio is working and you can hear them, right? So if they actually answer, that means we're in good shape. So that's
correct. Yeah. And then, but when they speak, I know they'll be announced, so I'm not going to worry about that too much. Next, I have Judy Peakley.
Good morning.
Okay, that's awesome. Marie Sandoval.
Good morning.
Sounds good. Rick Vincent.
Morning.
I feel like I'm in school. Okay, Kelly Champney.
Good morning.
That sounds good. Amy Vaughn.
Good morning.
Mark Stanislas.
Morning.
Okay. Brad Crump.
Good morning.
And Peter McDonald.
Good morning.
Okay, everybody sounds good.
Great, thank you. So before we go on the record, Sunny, what I'll do is I'll call the meeting to order. I'll administer the oath to the group. And if everyone can just say whether they affirm collectively is fine, and then I'll confirm that no one did not. So we don't have to go through one by one. And then after that, I'll just turn it to you for the presentation.
Thank you.
Okay. We can go on the record, Michelle.
Okay, on the record.
All right, good morning. It's August 28th. Today we have the University of Vermont Medical Center's presentation and hearing on their fiscal year 25 budget. We're joined by the UVM team and its CEO, Dr. Sunny Eppen, and I'll administer the oath to the UVM folks. If you can please raise your right hands. Do you solemnly swear that the evidence you shall give relative to the cause now under consideration shall be the whole truth and nothing but the truth, so help you God?
I do.
I do.
And were there any testifying witnesses for the University of Vermont Medical Center that did not affirm the oath? Great. Thank you very much. Dr. Eppen, I will turn it to you. What we'll do is I've allocated 70 minutes for your presentation. If you need to go a couple over, that's fine. We have a big budget here and a lot of questions, so I wanted to make sure you have ample time. So we'll go till 9:20-ish. If you need a little bit more, let me know.
10:20.
Oh, sorry. Yes,
Yeah.
correct.
Thank you. Chair Foster, members of the Green Mountain Care Board, thank you for taking the time with us for a collaborative review of our Vermont hospital partner budgets for the 2025 fiscal year. My plan is to provide a brief overview of our priorities, and then leaders from each of our hospitals will speak to their FY25 submissions. Of course, today, just the University of Vermont Medical Center. I'm happy to share with you that on the whole, our Vermont hospitals are more stable financially. This is based on a number of factors, including administrative cost control, delaying needed capital investments, improvements in patient access supported by the integration of our health system, and leveraging that integration to reduce the cost and reliance on temporary labor. We also did receive some one-time funds in FY24 for expenses incurred during previous years, including the pandemic. These included FEMA grants and employee retention credit funds. But despite this positive progress, we're not where we need to be able to best serve our patients and communities. We have more work to do, and we know it. Everything we do as an organization, including these budgets, are guided by the principle of how do our patients and communities access the high-quality care they need, deserve, and can afford. To that end, our proposed budgets for FY25 respond to clear direction I've given our leadership team, which I believe mirrors the guidance that this board has shared with us. Those directives are increase timely access to care, make care more affordable, and provide high-quality care by continuing to improve patient experience and outcomes. Given the shared challenges we face in our state, we won't be able to achieve these things overnight or in a single fiscal year. But they serve as our North Star. We strongly believe the budgets we're presenting will make progress towards these goals. These budgets also represent a significant effort to control expenses at a time of persistent increased costs for pharmaceuticals and supporting our workforce. The commercial rate and NPR requests for each of our budgets represent our cost control initiatives. You'll hear more detail about the specific work we're doing in our presentations, but I want to take a few minutes to share some of the initiatives I'm most excited about and are supported through these budgets. As an integrated academic health system, we're proud to offer high-quality, leading-edge medicine to our region. Thanks to the work of our providers and staff, we're helping our patients at every age be as healthy as they can be to drive better outcomes and better utilization. But we know more people need this care than we have the capacity to serve today in a timely manner. We've been working very hard to improve physical access to care. We're reducing wait times and reducing backlogs for surgeries and imaging. We're also increasing access to specialty care and getting our patients in faster answers about their care through our very successful e-consult service. For example, nearly 90% of e-consults performed eliminate the need for a separate patient referral appointment. Our FY25 budgets also support greater access to primary care, which we know is the foundation for healthy communities. To increase capacity, we've hired skilled clinicians and staff to support our providers. We're leveraging technology and reducing obstacles to productivity and protecting that precious time spent caring for patients. Next month, we'll begin patient self-scheduling for our primary care clinics throughout MyChart portal. Patients will be able to select for themselves the soonest available appointment at the location they prefer. And patients with MyChart can sign in onto a new program called FastPass that offers appointments when their providers have a cancellation or new availability. In July, 249 patients accepted FastPass offers, and they were seen on average 50 days sooner than they were originally scheduled. Of course, all of these strategies require investments, but they're opening more spots for patients to get care and represent significant cultural change within our organization to be able to deliver. Physically accessible care is vital, but we know it doesn't matter if you can't afford it. Everyone here knows healthcare in America is expensive, both for those receiving care and those who provide it. As a nonprofit health system, we balance our responsibility to our patients with our need to be sustainable. We're currently engaged in the work to reduce costs so we can focus on delivering the best possible care to our patients. I think, as all of you know, there's a lot of data out there on hospital cost. Understanding that data is critical before relying on misinterpretations that could have a profoundly negative impact on Vermonters. I hope the board and the staff will work to understand the more complete and accurate analysis so that they have a truer picture of administrative costs here in Vermont before coming to any conclusions. The fact is, based on the 2019 Dartmouth Atlas study on Medicare spending per beneficiary, the 3 health service areas UVM Health Network serves, Middlebury, Burlington, and Berlin, are the lowest cost centers in the country. According to the data available to us, we're continuing this trend in 2024. Additionally, the 2022 Cooper analysis shows that no matter how you look at it, spending per beneficiary in the Burlington Hospital referral area is low for Medicare, is low for Medicaid, and it's low for commercial insurance payers. Let me be really clear. I understand that being comparatively low doesn't mean we're inexpensive or that we can't do it better. Every day there are Vermonters looking at hospital bills or insurance premiums and wondering how they're going to make ends meet. But we must also be mindful of the investments that we need to make in order to support our patients and our communities. These budgets reflect those investments, as well as efficiency and cost-saving initiatives. Reductions to these budgets will negatively impact the people we serve. One way to achieve greater affordability is through our financial assistance programs. Last year alone, we saved roughly 11,000 eligible Vermonters nearly $30 million by covering the costs of healthcare and prescription medications. We're committed to continuing and expanding these programs. Finally, our FY25 budgets represent a significant investment in care management and population health services to be expanded to the majority of our primary care clinics. Care management is designed to provide patients with wraparound services in addition to their doctor's appointments. Examples include working with patients to ensure that they know how to take their medications. Do they have access to healthy food or transportation available for their needed appointments, along with many others. Through these investments, we're able to keep our patients healthier and out of more expensive care settings like emergency rooms or hospitals. That helps us control costs for them, for us, and for payers while making care better. In addition to the greater physical and financial access, we're committed to providing the best care possible. This year's budgets include support for elevating cancer care to the current standard of care in America by building on submitted or soon to be submitted CONs to upgrade our linear accelerators at CVMC and at UVM Medical Center. And we're prudently moving forward with UVM Medical Center's Outpatient Surgical Center. We all know that this project is needed to meet the growing demand for surgical care while improving patient outcomes and controlling costs. Of course, the success of this project will be based on our ability to operate the facility sustainably. As I mentioned earlier, our work must be balanced with controlling cost growth for families. We know they're feeling financial pressure at the grocery store, for housing, and at their doctor's offices. For FY25, we have scrutinized every line of investment and expense. Our commercial rate and NPR submissions reflect that effort. It's also important to note that working together as an integrated health system reduces our costs. We realize savings from shared administrative functions like human resources, accounting, and IT, to mention a few. We're also being more efficient with our leadership. For example, Porter Hospital shares its president, chief financial officer, and chief medical officer with our partner hospital in Elizabethtown, New York. This reduces administrative costs while sharing ideas and best practices among hospitals that serve similar communities. This efficiency is reflected in the senior leader level of our network also. The most recent Gallagher study shows our health system is at the 20th percentile when comparing total direct compensation to net revenue. When you look at it as a percent of our total payroll, we're at the 14th percentile. Based on data from Syntellis, a strategic planning, enterprise reporting, and performance improvement platform, our model's been very successful, and we've held our administrative service expenditures below average compared to other similarly sized academic medical institutions across the country. In FY24, following this board's decision on our budgets, we tightened our belts and eliminated nearly 130 open administrative positions across our organization. This saved us approximately $20 million. But this action did not come without other costs, as it put more pressure on our people and delayed implementation of some access initiatives as a result. As we continue to make progress in controlling costs, our workforce is by far our largest expense. We know that there's broad support in government and our communities to recognize the efforts of our dedicated people. They deserve it. We believe we're meeting that expectation, but we have to acknowledge that this is expensive. We know there's more we can do, and we're actively working on the things within our control. But none of us can deny the hard truths that shape healthcare. Much of this was reinforced and showcased by the board's consultant under Act 167, Dr. Bruce Harmony. His recommendations and suggestions include among them that our population is getting older. They need higher acuity care and more of it, which increases cost pressures on all of us. There's a lack of housing and childcare that makes it more challenging for hiring and retention. There's still not enough post-acute care beds and mental health capacity to shift patients out of the hospital into more appropriate care settings. This continues to drive up costs. And the broken fee-for-service model isn't helping us get out of this quagmire. And because Medicare and Medicaid do not fully cover our costs, employers and people covered by commercial insurance are shouldering the majority of cost inflation. We understand this nationwide issue, and so we've been working with our partners at Dartmouth Health and Maine Health to advocate to our federal delegation in DC to address rural hospital underfunding. Our federal representatives understand this problem, and we're going to continue to work with them to move this agenda forward. So in closing, I want to say that despite these persistent challenges, I am truly hopeful, and that's because of our people. Every day, I see them working with compassion, kindness, and resilience to provide the care our patients need. Their efforts have moved us closer to our goals, and I'd like to thank them publicly here today for the work they do. Beyond our thanks, though, they need our support. There's more work to be done, and the budgets before you reflect the steps forward that we need to take in FY25. I also want to recognize the leaders who are presenting to you this week. Each of them has spent countless hours working on these budgets. They have the very difficult job of being held accountable by you, by me, our trustees, our communities, and most importantly, our patients. And lastly, all of us hopefully will soon receive the final recommendations from Oliver Wyman. We look forward to working collaboratively to achieve sustainable solutions for Vermonters. It's our hope that moving forward that we can be a valuable partner to you and your staff to advance our shared goals of making care more accessible and more affordable. Thank you for your consideration today, and I'm going to hand it over to Dr. Stephen Leffler to start the University of Vermont Medical Center's specific budget process.
Thank you, Dr. Epen. And I think yeah, there they are. Thank you. So just quickly, my name is Steve Leffler. I'm the president of the UVM Medical Center. I've been at the UVM Medical Center for 31 years. I'm trained as an emergency physician, and I've been the president of the medical center for about 5.5 years. Next slide, Elliot. So today, our team is going to talk about the UVM Medical Center and the purpose that we serve in Vermont and our region, what we need to provide high quality, safe care to the people and communities of our region, our work to improve access to high quality, affordable care, the value of our network, our patient net revenue and commercial request, and supporting evidence to support our ask. Next slide, please. Next slide. UVM Medical Center has a referral region of about 1 million people, and our HSA has 178,000 people in our local HSA. To remind everyone, we're both a community hospital and a tertiary care academic medical center. That's somewhat unique for AMCs, but it makes delivering care here a very rich experience for our providers and learners. But it does come with challenges. We employ 8,364 people, including almost 1,200 providers. We help train 1,500 students every year. We have 562 beds and see about 1.3 million patients per year. Our emergency department in 24 is going to see 68,550 patients. I'll just note that when I came back to Vermont in 1993, we were seeing about 30,000. So more than double the volume over the 31 years I've been here. We're the academic and tertiary care anchor for the health network and the state of Vermont. We're Vermont's only academic medical center. We're a level 1 trauma center. We're the children's hospital. We're level 2 pediatric trauma center, basically just because of volume. We meet all the requirements to meet level 1, but we don't happily see enough sick children per year to meet the requirements to be a level 1 pediatric center. We have an award-winning neonatal intensive care unit. We have cancer care, and we're providing the highest levels of cancer care here with new therapies like CAR T-cell. We do transplants. We provide high quality advanced surgical services through our hybrid OR, interventional radiology, and so on. And we're the reference laboratory for many other hospitals in the state of Vermont. We win national awards on a yearly basis. You can see that we're in the best regional hospitals of U.S. News and World Reports. We've received awards from CMS, American Heart Association. Our NICU won a Human Experience Award winner from Press Ganey in the top 5% of NICUs in the country for patient and family experience. Next slide, please. Next slide. So this is from Oliver Wyman. All of us saw this on the 167 hearings. Burlington is becoming older. Older people require more and complex care. And if you look at this chart between 2020 and 2040, you can see that the percentage of older Vermonters is rising. You can see the percentage of Vermonters between 65 and 74 is increasing, somewhat decreases slightly for 20 to 64-year-olds. And overall, the number of people we're seeing also is increasing. So more older Vermonters who require more care, but Chittenden County is also growing in the state of Vermont. Equally challenging, as we're having more patients need our services, the working age population is declining, meaning competition for the people who work at the medical center is increasing, and we need to be able to pay them fair and competitive wages to attract people to come here and to stay. As the slide notes, we're going to see more cancer care, more heart disease, more strokes, which will need tertiary care. Next slide, please. Population change is really driving demand. Compared to 2019, the UVM Medical Center has seen an additional 24,000 new unique patients each year compared to 2019. So our number of patients served has grown and continues to grow. On top of that, we're doing more complex care. As I already mentioned, CAR T-cell therapy, We're doing more advanced cardiac surgery. We're adding ECMO to our cardiac unit. We provide hybrid OR care, which is high-end vascular surgery, the only hospital in the state of Vermont that does that. When people need it, they need it urgently, and we're very fortunate and proud to have that here. And I just want to note that over the last 460 days, more than half of them, our census has been in red. I talked about this in the past. Green census means everything's fine. We have no issues. It's going to be not a complicated day to take care of everyone who needs us. Yellow days are a little tough, but we'll get through it. We can manage. Orange, you start having to move some people around. Red means every day you're trying to figure out how we're going to care for everyone who needs our care on that day. That's more than half the days that we have. Next slide, please. Post-acute care is a major challenge across the state of Vermont for all hospitals. We're very aware of that, but also for the academic medical center. Yesterday morning, we had 75 people that were ready for discharge, but had no safe discharge location to go to. That's a huge amount of our med-surg beds and really impacts ER boarding and getting all of the cases done and accepting transfers from across the state. You can see in these two charts, the top chart, the orange, is people that have been here more than 20 days, basically continually going up. The people who've been here from 11 to 15 days is somewhat stable, but subacute census also is gradually but steadily increasing. In 24, we opened a subacute unit within the hospital to improve throughput, to be able to get more people out of the ED on a daily basis and to maintain our volumes of other important procedures and continue to accept all transfers. That's not an ideal use for that floor, but that is what we're doing right now to help manage the pressures that we face every day with all the people who need our services. Next slide. This is our emergency department data. So if you look compared to prior to 2023, our emergency department is seeing about 20 patients every day more than historical averages. We feel it every day. A lot of those patients, I would say, are local community patients. Those are people that are in our local catchment area, our HSA, that need emergency services. And so we're very typically seeing 185 and 200 patients a day. When I was practicing full-time emergency medicine, a 200 patient day was huge, very unusual. 4th of July, New Year's Day, now we hit it almost every week. On top of our emergency department local volume, transfers into the medical center, we average about 450 transfers per month. And I just want to note that every day almost, there are still more people that need to come. They've been identified by the other hospital that they're at as needing tertiary care service, but we oftentimes have to slow that down or delay a bit to have a bed available. It's part of that whole red census challenge that we face on almost every day. Next slide. So we know that when patients get into the medical center, they typically have a great experience. We see Press Ganey data every day that patients value the care they receive at the medical center. We hear still oftentimes too much that people still have trouble getting into us. Our challenges are really in 3 areas to improve access to care. Space, we're very space challenged. Every location you look at, we know, like we've already talked about, the NICU is half the size it should be. The emergency department probably needs to be about 100,000 volume emergency department at this point. We're short of inpatient beds. We have OR capacity issues on a daily basis. And so space is a major issue. Providers, we're working hard to recruit providers and retain providers that are here and support staff to make sure that our providers are working at the top of their license and doing what we need them to be doing every day. We are very focused on addressing each of these challenges in multiple ways. Next slide. Space. We know that space must be adequate to meet the care needs. It must be secure. Now we really are trying to make sure all space that we have is secure and safe for the delivery of care for our patients and our teams. Lack of space equals red census days and access challenges getting into outpatient care. Our providers need adequate staffing. We hear every day from our providers that they don't have the full support of what they need around them to see as many patients as possible, as efficiently as possible. We really want our providers to be really working on patient care and not other functions that really don't add value to the care experience. Support staff is critically important. We need to make sure that we have enough administrative and clinical support roles to be able to serve our patients. Room turnover time is critically important for patient movement and satisfaction. We're hard at work on that right now. Next slide. So at the medical center, we actually have a dedicated throughput team that every day looks at making sure we get people through the hospital as quickly as possible. It's very focused on length of stay. We've had a length of stay initiative all year led by our Chief Medical Officer, Isabel Desjardins, our Chief Nursing Officer, Peg Gagne, to make sure that our length of stay is as low as it safely can be. We've added patient discharge spaces. So when we have someone that we know is going home that day, mostly in the Miller building, we'll move them to a discharge space so that bed can be prepared and take a patient that needs the bed for acute services. We've already mentioned we have a temporary, hopefully it's temporary, non-acute unit. All Feeney Allen ORs are being utilized right now to provide surgical care. We're starting the planning for the outpatient surgery center, which will add capacity for patients who can get outpatient care. That will help both the main campus by moving outpatient care to that site and help add to other types of surgery that can be done in that center. We did a lot of work on our hybrid OR this year. We have the only hybrid OR in the state of Vermont. It has a long time for it gets scheduled far in advance because we know it's needed. And we've upgraded that unit to make it more reliable. It had a significant downtime as it was aging out. And we've added additional imaging equipment such as 3T MRIs, CT scanners, Da Vinci robots to provide high quality service in a more timely way. For our providers, we've improved block scheduling to improve access to care and make them more efficient. And we've had some recruitment success we're really proud of. We've added a CT surgeon, an IR radiologist, a GI doctor, urologist, and anesthesia and emergency medicine have had good recruitments. That's not all we need, but it will help with our access challenges. Our new contract for support staff has increased wages. It has really helped us with recruitment and retention, and is adding to productivity for our providers by improving staffing. And where it's appropriate, we're using AI to make sure that we're being as efficient as possible. I'd now like to introduce Dr. Marie Sandoval, who's going to talk to us about primary care, specialty work, and highlight some areas that we're working hard on right now. Dr. Sandoval.
Thank you, Steve. Hello, everyone. Good morning. I'm Dr. Marie Sandoval. I've been a primary care internist, I can't believe it now, for 26 years. I'm also the primary care lead for our primary care specialty care collaborative effort, and I do work in the IT department. I'm the medical director for digital health. So first, I'm going to talk to you about some things that I'm super excited about, and that's primary care access and some of the things that we're doing in regards to efforts to enhance our access for patients and increase efficiency. One of the first things that you already heard a little bit about is we moved to risk-adjusted panels, and we determined, instead of just looking at our panel sizes, we looked at our medical complexity of our patients, also additional social determinants of health. And what this has allowed us to do is open many primary care practices that were previously closed. So that's been a wonderful opportunity. We also are doing collaborative care models, and you heard a little bit about this. And what this does is it opens our primary care clinicians by accessing other type of skilled clinicians to give our patients what they need. So examples of this are our nurse case managers, which you heard a little bit about, and how they benefit and help me to take care of my patients. Our social workers, if I have a patient and has a mental health crisis, I can contact them. I can have the patient see them. I can have the patient see our primary care medical home behaviorists also. So it gives me some flexibility about caring for patients and all of our primary care clinicians. Lastly, we've had this wonderful opportunity that we did some scheduling simplification. So what this means is we standardize our schedules across primary care. This was extremely important to allow our patients to use the tools that we now have available in regard to scheduling. You heard a little bit about this, but it's really exciting. So what this will allow our patients to do is they're going to actually be able to schedule their own appointments through MyChart, which they are thrilled about. we are going to be able to actually send something called a ticket. So if I have a patient that I want to see, or if my nurse sees that a patient needs to be seen, they can be sent a ticket through my chart, which allows them to schedule their appointment straight from that ticket, which is fantastic. Patients are super excited about this. And lastly, you heard a little bit about the idea of a fast pass. So what a fast pass does is it gives patients the opportunity that if they have an upcoming appointment that's in the future and we have an opening and a cancellation or something that happens, we can send a fast pass option to a small number of patients, and whoever is able to take that the soonest, they're able to get that appointment sooner. And we will be doing that for our new patient visits, and we're very excited about that. And patients are excited about that opportunity also. All right, next slide, please. Along with our work to increase access to primary care, I'm really thrilled to talk to you about our increased access to specialty care. So in the past, as a primary care clinician, I had two options to get specialty care help. Number one, I could do it curbside, which nobody liked, and it was really challenging. I had to interrupt my specialist to get some information about a patient. The other thing I could do is put in a regular referral for a patient to a specialist, which meant they went to a referral queue, and sometimes I didn't even know when that patient would be seen. So what we've done is developed our electronic consult service. Electronic consults, as you heard a little bit about, are an ability for me to ask my specialist about a clinical question about a patient that's going to be answered solely through the patient's medical record. It's asynchronous, so the specialist can answer it when they have time. They have dedicated time for that. And it is all done, as I said, through the patient's medical record. They don't need to be seen in person. As you can see, we currently have 57, and that's a little bit wrong. So we're starting another one today. So we're actually up to 58 e-consults, which is I'm thrilled about, across our entire network for our clinicians. You can see what our medical center has done year to date in regards to the number of e-consults that our specialists have helped us with our primary care patients, which is a 50% increase from last year. And what's wonderful about these is quick turnaround. So these patients typically I hear back about my specialist recommendations less than 7 days. I keep the care in the patient's medical home. I'm actually following through with those recommendations. Patients don't have to travel. They don't have to take time off of work. They don't have to have childcare, which is fantastic, which they love. Also, it's documented the medical record. They can, I can search it, I can see it, and they can see it. So if a patient has my chart, they actually are able to see their e-consult recommendations in their medical record, which is fantastic. Let's say I have a more complex patient situation. I need a little bit more help with a patient. Now, what we've also developed is something called an enhanced referral, which I'm thrilled about. So what an enhanced referral does is when I open that order, it's a tool that actually asks me clinical questions. And based on those clinical questions, it helps me to actually triage how soon the patient needs to be seen. It directs me to place the order in that way. And then we have dedicated urgent appointment slots for those specialties that the patients are seeing more urgently. The order also directs me, it tells me what tests the patient needs to have done. So if they need specific labs or images, so that when that patient actually goes to that visit, it's a much higher quality visit for the patient, for the specialist. They don't have to come back because those things weren't ordered, which is really wonderful for those patients. It directs me. So let's say I'm going into a specialty and I realize like, oh, I wanted to have this patient seen for, let's say, something like a positive ANA. Actually, the enhanced referral will direct me, oh, there's an e-consult for this. Why don't you place this first? Because then we can make sure, does the patient actually need to be seen in person? And for some specialties, there's just patient education. So they'll say to me, this patient doesn't need to be seen for this specific problem. Instead, why don't you use this education? And then if you still have questions, please let us know. Along with all this, there's been some fantastic benefits for me also, because as you can tell, I learn from these e-consults and I learn from the enhanced referrals. We've looked at specifically rheumatology here. It was our first enhanced referral that we had. And here at our medical center, we've had a significant reduction in referral volume, reduced wait times for that specialty itself. The next thing that we've done is called the Refer Back Initiative, which is wonderful. What that does is patients who are in our specialty practices who are really not getting anything new with their visits, things seem very stable, our specialists are referring back to primary care with a contingency plan, basically saying, if you need me to see this patient again, let me know, or here's a plan of what I would have us do if that was the case. But as you can see here at the medical center, we've created 370 new specialty slots based on those refer back. So what I can say about all of this is these are the things that I've noticed. patients get faster access to specialty care. They're getting higher quality care. They're letting me know, other people are letting me know, and there's this increased access, and we have to think of access in a different way, just having that ability. The other thing I'm seeing is that our clinical, our clinicians, primary care clinicians are feeling that. They're feeling like they're able to get in touch with their specialist colleagues much quicker and getting higher quality. And we're learning from it, which is fantastic. Our specialists are also appreciating this collaboration. They're seeing the referral queues numbers dropping, and they're feeling like they're really getting higher quality consults and in-person visits. And another thing that's really important is our learners. So our learners are noticing, our residents and our fellows, that the visits they're having with patients because of this work are really higher quality, more fulfilling visits. So my presentation. Next.
Good morning. I'm Rick Vincent. I'm the Chief Financial Officer for the UVM Health Network. I've been here one less year than Steve, so I've been here 30 years. Grew up in a small town in the Northeast Kingdom, so I've lived in Vermont my whole life. As Sunny mentioned, we wanted to talk in our presentation about affordability. We obviously understand that healthcare in America is expensive, but we wanted to become a little bit more educated on the levers that impact affordability. So we actually commissioned a study from Milliman to better understand what are the things that both we could do and what our partners could do to help improve the affordability of healthcare in Vermont. So one of the key learnings from that engagement is that coming up with some type of definition of affordability is critical. Right now, for us at least, it's difficult to kind of understand what is affordable, and so what we glean from that engagement is that perhaps a way to kind of ground ourselves around a metric that we could all work on is to look at affordability from the lens of how much of Vermont residents' income goes to healthcare costs, with those healthcare costs being premiums, out-of-pocket costs, but also factoring in the subsidies and the tax credits that they receive. What we found, I think the board and the staff have seen similar data. When you look at Vermont, we're at about 10% for individuals and small groups, 10% of income going to healthcare costs, and about 10.6% for employer sponsored plans. That does, again, for any of these data, these data elements, you want to try to triangulate and find other sources that also tell you hopefully a similar story. And so in the 22 Commonwealth Fund, they too placed Vermont at about 10.3%. And same thing in the Statista study, that they both had the national median at around 11.6%. So this is just to set the frame that perhaps this is a way that we could ground ourselves in a metric that we can work towards, because without that, without a more concrete definition of affordability, it's going to be hard to figure out what we work on and whether or not we're making progress as we move forward. Next slide, Elliot. So what are some of the things that we're doing? Sunny touched on some of these in his opening comments. Obviously, we're doing everything we can to maximize the efficiency in our shared services. We're starting to look at pricing data because there may be some things that we can do in terms of pricing that would actually impact affordability. We're still in the early stages of that, but we now have better access to pricing comparisons and pricing data than we've had in the past. Obviously, something that we've done for many years is look for ways to eliminate waste in the care that we provide. So creating pathways that avoid unnecessary care is critical. Sunny touched on this. We've expanded our financial assistance policy. There may be some other things that we can do there to enhance that. Advocating for reduced administrative burden. So whenever we can make progress there, that actually allows us as a provider to reduce our costs. So there's costs that comes out of both the health insurance industry and the provider industry when we can make those types of movements. We're maximizing or trying to maximize the government payer reimbursements that we're getting. Sunny talked about the outreach that we've made with our federal delegation with Maine Health and Dartmouth to recognize the unique role that academic medical systems in rural parts of the country face. Next slide, Elliot. In terms of what we might be able to do together to help improve affordability. So a few of the learnings that we had through this engagement, there's definitely appears to be an opportunity to have Vermonters make more informed decisions on what is the best marketplace plan for them. There does appear like an opportunity where there's some more subsidies and tax credits actually that could help the affordability. Looking at things like silver loading, community rating, there's things that potentially could impact that. Act 167, we've talked about that, the capacity that we're providing across the state of Vermont. There's likely some opportunities to reduce costs there. And then finally, maximizing the federal funding available that's out there. We're doing what we can, but we can't capture those additional funding opportunities without some partnership to make that happen, and then to in turn decrease the pressure that the commercial payers and the patients of Vermont feel.
Thank you, Rick. So systemness is very important to academic medical centers. Academic medical centers work best as part of a system of community hospitals to make sure that patients get the right care at the right place at the right time. UVM Medical Center adds value to Vermonters by providing high quality, safe tertiary care, which is oftentimes more expensive. And so having other places across the state where we can put our patients in other beds for other important services helps all Vermonters to make sure there's a bed available here when they need it, and to make sure that we're managing costs as much as possible. Integration in the system is a path towards optimizing patient delivery and allows people to move to the academic medical center when necessary and back to their local hospital to be closer to home at the appropriate time. Next slide. So workforce development is crucial right now. We realize that we will probably not be able to recruit enough out-of-state people to fill all the positions that we need. Housing is a big issue. Getting people to move to Vermont is an issue. So we worked very hard to have UVM Medical Center be a place where people can start and be trained to have different positions while they're here. We have 52 nurses in development and training programs, 7 members of our technical staff working with Vermont College to have a respiratory therapy program. We have people that start potentially in EVS and could become a nurse or even a doctor of nursing by leveraging all the programs that we have. The programs typically pay people to work and go to school so that they can advance their careers. We have a Pathway to Excellence program in nursing, which is critically important for nursing development and for providing high quality care. At the network level, we've centralized traveling staff contracts, which has reduced variability and cost. And we have tuition reimbursement programs for all staff. Next slide, please. We are an academic medical center. We're very proud of that. One of our missions is to train the next generation of providers. We invest heavily in training physicians, scientists, nurses, and other healthcare professionals across the spectrum, which provides those providers to the state of Vermont. From 20 to 23, 113 graduating medical residents stayed in Vermont, and 25 of them are operating outside the system. They've gone to other hospitals or locations in Vermont. Research and innovation is critically important. We participated in COVID vaccine studies. Right now, we're doing a Lyme vaccine study. Having the academic medical center brings research to Vermonters that they can get earlier than they would otherwise. It improves patient care. We have world-class physicians that are here in Vermont because they can do research, because they can do education. That brings people to Burlington that otherwise wouldn't be here. We have multiple programs that have world-class providers that are here in Vermont because of our academic mission. Those providers are here, and besides the academic component of their mission, they provide outstanding care to our patients. We're very lucky. There's economic benefits to having an academic medical center. First off, many of these people have spouses that are come and take other big jobs, and they, between research, education, and other opportunities, it brings other dollars into Vermont. In 2020, the average annual support provided by an academic medical center to medical schools was about $100.6 million. So I do believe that the value that we provide to the state as an academic medical center far exceeds the cost of having one here. And I really believe that we can't afford not to be an academic medical center for the state. Next slide, please. Now back to Rick.
In the interest of time, I won't spend too much time on this slide. So connected to integration and our academic affiliation, there is a lot of transfers that happen between the organizations. This was highlighted by Professor Kane's presentation. I'll just say that these transfers are some of these we have to do because of GAAP accounting principles. Others are related to our corporate structure that we have to transfer funds between the organizations. I guess the key takeaways that we wanted to share is that our profit and loss statements reflect our actual revenues and expenses. These are really balance sheet transactions. And next slide, Elliot. And just again, very quickly, I'm sure there may be other questions on this, but just to give you a flavor of some of these large transfers that you see between the entities, are the way that we manage our investments. For example, you see the $100 million numbers on this slide here. We manage our investments centrally as a network, but we still maintain the balances that each partner has in their investment pools. So because of GAAP reporting or reporting requirements, we have to recognize those transactions. So really, when you look at these balances, it's one partner has a receivable on their books and another partner has a payable, is really what drives some of these large transfers. And we'll be happy to answer other questions on those as they come up. So now shifting to part of the presentation that we were required to present as part of the guidance that you gave the hospitals, which is if we're going to have a net patient revenue number that's over the guidance and a commercial rate increase that's over the guidance, you're looking for evidence that supports these requests being over the guidance. Also connected to this, we realize that the way that we justify our rate increases, both government and commercial rate increases, is that we've made the case for many years now that rate increases have to support inflation costs. And so in your, sitting in your seat, you obviously need to ensure that the base expenses that inflation is being applied to is at a reasonable level. And so the next several slides are the evidence that we're presenting to support that case, that both the base that we're starting from, both from a clinical efficiency and an administrative efficiency perspective, we feel like we're in a good place. Obviously, we're doing work in both of these areas, but again, hopefully, this gives you a sense that we're starting from a very solid place. This first slide, you've seen this many times now in our budget presentations. We felt it important to present it again to put our net patient revenue growth in the perspective of how many patients that we serve. The 3.5% guidance that we've been working with for many years now was always intended to be a per capita or per beneficiary cap, both in the all-payer model and in the statute. It speaks to that, that growth rate being anchored to the number of patients that you're caring for. So we've updated this analysis to hopefully help provide some context for the total net patient revenue growth for the three Vermont UVM Health Network hospitals. At the top part of this chart, we've estimated the population that we serve. In the middle section, we're making an adjustment for acuity essentially by using the age of the patients as the acuity factor. Steve and Sunny have highlighted that the age of our population keeps growing, and as you age, obviously you utilize healthcare services at a higher rate. So when you take that all into the mix, this is our estimate. When you look at 23 to 24 for the 3 Vermont hospitals and the populations that we serve, that the total net patient revenue went up by 3.3% from 23 to 24, and that our budget, the 24 to 25 budget, is going up by 3.7. Again, not a perfect analysis, but something that hopefully in the coming years we can move to look at the individual hospital budgets on a per capita basis as well. And with that, I'm going to pass it over to Judy Peakley.
Good morning. Thank you all. I am Judy Peakley. I'm the CFO for University of Vermont Medical Center. And given the tenure of those who've been speaking, I would be considered the newbie on the team, but I am not new to healthcare. So I'm coming up on my 4th year with the Health Network. And that is adding in and totaling over 25 years of experience in the CFO role exclusive to healthcare. I've also served in dual roles of CFO and COO in various healthcare entities, and I spent about 6 years with the advisory board out of Washington, D.C., who has been leaned on to provide experience, guidance, and expertise to healthcare around the nation. So with the experience that I have in 11 other states, I bring that with me coming from Nashville, Tennessee, if you pick up a bit of an accent. But I will say I am very proud to stand here today to serve in this capacity with University of Vermont Medical Center, and I'm proud of the services and the quality of care that they deliver. So I'm going to move us a little forward on the presentation here and get into some of the volume and the cost and the NPR crosswalks today. Dr. Leffler mentioned our increase in new, unique patients seeking care at the University of Vermont Medical Center. This chart gives you a bit of an indicator. So FY19 is that pre-COVID period that all healthcare systems have been looking back for a sense of normalcy. And so when we build 20, 21, 22, we're still looking at what is going to be the normal capacity and demand for services. That's happening nationally. But what is unique for University of Vermont Medical Center is that we're seeing new, unique patients seeking services here. So you see the downward trend in the FY20 due to COVID. Then you see, as compared to 2019, a slight bump in 21, 22, 23. There's the over 17,000 new unique patients sought services from University of Vermont Medical Center, and the 24,000 that Dr. Leffler referenced earlier in his presentation is reflected here. So we are projecting that we will see over 24,000 new unique patients at the Academic Medical Center for the state of Vermont. On the next slide, you'll see how utilization factors into the NPR crosswalk. It's a large increase from FY24 budget. This slide will zero in on utilization. Utilization, if you see on the screen, is $93.7 million of that $170 million change from FY24. So you saw the slide previously indicating the new unique patients over 24,000. This utilization takes that into consideration. It also takes into consideration the work that not only the Green Mountain Care Board and the communities have asked us to do to open up access, but what we've actually been able to accomplish in opening up access, and thus you will see higher utilization. When I look at other factors that go into our NPR crosswalk, you can see that what we're actually getting on our rate and our payer mix is having little impact on the overall request for FY25. Our actual experience on our budget rate is actually, if you look down at the bottom, is only off by 0.3%. And given the large dollars we're talking about, that is what I would consider nearly on. Same thing with our payer mix. While we've had some shifts within each of those, overall, it's coming in, the two of them, in less than 1% variance to our FY24 budget. So then that leads us to the 5.1% variance from the FY24 budget, all based upon utilization. Now, when you compare our NPR to our FY24 budget, you're going to see, when you factor in inflation, that it's higher than the FY24 budget, but that is because we're actually seeing higher costs related to delivery of care in our actual FY24 numbers. So that is why you'll see a little bit of variance between what staff has at 4.9% and what we have at 4.7%, because we are taking into account actual experience. So going back to the top of the grid here, you see $89.7 million in cost inflation that is impacting our rate and our NPR increase. Leading the two of those, the utilization and the cost inflation, which we'll delve into more, is what is really driving our $170.5 million NPR increase, or 9.3%. The next slide will just take us into a little bit deeper snapshot of our collection rate, which I said was nearly spot on in overall. For our FY24 budget, you can see the slight difference that we're factoring in for FY25. I will say what we are seeing is a little bit of shift in all other, and so you'll see that collection right there as we've adjusted for how our payer mix is coming in. So you can see that change is less than 0.5%. And the next slide, please. And then we go a little bit deeper, and this is the other part of the spreadsheet, just blown out a little bit, showing the $6.9 million variance on NPR by payer mix. What you will see here is that we've adjusted slightly based upon what our actual experience is for FY24 and reflected that in our FY25 base. One assumption that we did have in FY24 was that we did assume a higher percentage of Medicaid redetermination patients and population would enroll in commercial plans, but we have seen an actual uptick in more patients moving into a self-pay payer category. And we do expect that that will have impact on our free care, as well as our bad debt. We do think that some of the things we've implemented to aid the population with applying for assistance will help to minimize the impact of bad debt, but it will show up in our free care. Next slide. So this is more on the utilization component. And when you look here, here's the $93.7 million in the utilization and how it is spread among the different payers. So you can see 51.7 to major commercial. You can see how we're expecting bad debt on the utilization changes. And then you can see what has been driving by our key volume metrics on the side. So you can see that our FY24 annualized, what we have there, compared to our FY24 budget for each of those volume metrics. So as you look to the right, you see that we don't have significant changes in a lot of those areas, and that is because utilization on a lot of these areas is based upon capacity. We did a significant amount of work in FY23 with Path Forward into FY24, and we continue into FY25 to open up that access. Thus, it relates back to the utilization increases that we have been seeing. But if you look at our 24 to 25 change, we're still focusing on ensuring that we're able to get patients to be able to get their mammos, their CTs, their MRIs. We are focusing on in FY25 trying to increase access for GI and endoscopy services because we do know that there is a need for that. So the note below that just talks about the service areas that are that we're seeing drive that utilization, and then what we call nursing is related to our inpatient services. As well as the other list of services that you see below. The next slide talks about the NPR increase and what I refer to as reimbursement. So it's not just about what we charge, it's really about the need for reimbursement to increase. And that increase of 89.7 is tied to cost inflation. You can see on the screen here that cost inflation and how it is spread among the different payers based upon the reimbursement expectations that we have for Medicare, Medicaid, and as well as the impact we think the cost inflation itself will have on bad debt and free care in terms of increasing. We also take, so how did we get to the 89.7? The 98.7 that was on the prior screens, we are reducing that and trying to lessen the burden by removing the pharmacy expense and also offsetting with some other revenue, bringing it down to 89.7. On the right side of it, you can see how that cost inflation is spread, with the majority of it being in wages, salaries, and benefits. And then each category and what wage inflations we have for those, as well as the salary, non-salary expenses, and the inflationary factors that are attached to those as well.
Ms. Peakley, I just want to interrupt for a second. It looks like we're on slide 34 out of 58, and we're scheduled to go till 10:20. So why don't we add an extra 15 minutes and go to 10:35? But I know the board members have a lot of questions about this material. So let's just be mindful of time because we do have a lot, and I definitely want to stay on schedule as best we can this year. We didn't do a great job last year, so thank you.
Thank you. I do think that this is what I would consider a lot of the information and slides that will need to support some of the requests that we have, and hopefully it will also answer some of the questions that the board members have. So thank you for that extension. So as we look on to the next section of supporting evidence for our request, you can see on the next slide, this is what we did submit as a revised rate requirement to the Green Mountain Care Board after our July 8th submission. And we did send along with that the letter for the reasons. And also we noted that we do expect to receive more in our GME IGT line. So we included that, which also helps to lower the required funding to 56.2 million and converts to the request that we have at 7.91%. Next slide again is walking through our commercial rate increase and the components of it with our inflation and rate, as well as again how it is spread and among all the payers and relates back to the 7.91%. Something that is important to note on this is that approximately 1% of a reimbursement rate increase is equivalent to about 7.1 million. But at the bottom of this slide, you will see that of that, the 7.1 million does not go to margin, or it does not all go to expense offset, because there's a factor for bad debt, free care, reduced expenses for our patients, as well as provider tax. So we end up with about 6.5 million out of a 7.1. Next slide is just to show evidence of where the academic medical center typically has historically run and continues to run in terms of our expenses. So you can see us in orange, and we run, you can see typically right between the 25th and the 50th percentile. Something else to note is that for academic medical centers, you can see all quartiles and percentiles are actually increasing as the years have gone on post-COVID. Next slide is just another look at that in terms of expense per adjusted patient day. We again run between the 25th and 50th and below the 50th percentile here. So indicators of efficiency. And then the next slide again just shows that where we land at 24,000 per adjusted discharge is both below average and median. Something that has been asked and also demonstrated by some of the consultants is about Medicare cost coverage. So some things to note that are unique for University of Vermont Medical Center is that up until March 31st, 2012, University of Vermont Medical Center was paid based upon the Boston Wage Index. That did cease at the end of March 2012, and you'll see that in the graphs that we're presenting today. Something else to note is that the Medicare wage index does not, it typically is about a 4-year delay. So what happens today will not be reflected for 4 more years. And it's also not just a factor of what our wages are, but what are the wages of the nation, and how do we factor into that? So it is quite complex, but we are attempting today to just give you a couple of components of our Medicare cost coverage, as well as what we are doing to try to improve that cost coverage. Let's take a look at that on the next slide. This slide, you can see that Boston Wage Index in 2011 and 2012. You can see we had a much smaller gap in terms of our coverage, $5, $283. You can see when we lost the Boston wage component there, you can see that the amount of wage index dropped to 38.40, but we were keeping it fairly tight until you move to the bottom section of this slide. And you can see 2019 had, again, a little less than $3 on our variance. 2020, you can see that the wages, actual wages per the cost report, starting to climb, and you can see that continue in 21, 22, 23. And of course, these are wages based upon the calculations in the cost report. So 24 and 25 are, of course, not available yet. But you see the delay in the Medicare wage index, area wage index adjustment by 4 years is certainly creating a significant gap in coverage based upon the wage pressures within our facility and within the state of Vermont, creating a larger gap from Medicare coverage. Next slide, please. Oh, apologies. Can we go back? Sorry. Thank you. One thing I do want to note is on 22, you can see we were at 75% coverage. 23, you're seeing that go up to over 80%, and we are projecting that for the future. So how are we getting more coverage if the wage gap is growing? So what we did was we applied for and received approval to be considered So community hospital, and that goes into a part of the payment factor from Medicare. It's not impacting the wage index, but it does impact part of our payment methodology. So you can see that the improvement in our cost coverage does exceed 80%, 23 and forward. If wages settle and the wage index starts to get closer, then we will see that coverage improve further. Thank you. I'm going to send it back over to Rick Vincent, please.
These next few slides, I think we'll be able to get through fairly quickly. But again, in terms of additional evidence of our administrative efficiency, we've updated our comparisons here to the Centellus benchmark. So when you look at total network shared administrative shared costs as a percentage of total expenses, we're at 11.6%. The benchmark is 12.2%. In addition, the trend has been going down, so that 11.6% is lower than it was last year, and we continue to focus on this area to become even more efficient. Next slide. This data, which is the NASHB, is another data point that's been used to highlight essentially the UVM Medical Center is not administratively efficient. We're actually putting in our presentation to show that we are. And the reason we are is because the data that NASHB uses for this administrative to clinical salary ratio it's not that it's incorrect, it's just incomplete in terms of how they calculate the data. So if you look at the green columns on here with the specific cost report references along the bottom, that is how NASHB calculates this ratio. They take administrative salaries divided into clinical salaries to come up with that ratio. What they don't do, however, is factor in hospitals that are part of systems and what the home office cost report for that system, what costs that they actually allocate back to those hospitals is not reflected in the way that they calculate it. So if you look at the blue columns, that with, again, the cost report sources at the bottom, if you were to reflect the home office cost report adjustments, that paints a very different picture of the administrative efficiency of the UVM Medical Center, but it also paints a very different picture of the administrative efficiency of many of the hospitals that are in that data source that are part of a system. And that's really the bigger story here than just adjusting the UVM Medical Center. It just highlights that these other hospitals that are part of systems are in the NASHB data are dramatically underreporting their administrative costs. Data's not inaccurate. It's just that NASHB needs to take another step to make it more accurate. You see it very clearly with the Albany Medical Center. So if you were to look at which is the third one from the bottom there, if you were to look at NASHB and just calculate that ratio for them, they have a 0 administrative salaries in that database. But when you take into account the fact that they're part of a network and they do get an allocation from their home office cost report, they have $75 million worth of administrative costs that are not included in the calculation. So when you look at this with those adjustments, the UVM Medical Center is at 25.3% for this ratio, and for the Green Mountain Care Board peer group, the average of the group is 37.6, and the median of the group is 27.7. Next slide. This is just the same analysis that highlights using the Tom Reese analysis that was presented to the board in early July. The 46 academic medical centers that were part of his analysis. The average of the 46 AMCs was 34.3, and the median was 31.8 compared to the UVM Medical Center's 25.3. Then finally, this is just to highlight, the UVM Medical Center is unique in the fact that we have not yet created and what creates this, this issue for hospitals that are part of a system. We have not yet created a UVM Health Network entity that pays for all of our IT personnel, revenue cycle, HR. So for example, I am not a UVM Health Network employee. I'm a UVM Medical Center employee. And there are not many academic medical center networks out there like us. Most have created a network structure to house those expenses, but we have this slide in here just to show that there are others out there, but there's just not very many that are like us. Next slide. Sunny hit on these 2 points in his opening remarks, so we can quickly go through this. But just to highlight on this slide here, actually, you can go to the next one, Elliot. Down at the bottom, when you look at the senior VP and above costs for the UVM Health Network as a percentage of total payroll, the very last line at the bottom, you can see that UVM Health Network is at the 14th percentile. Again, another measure of what we're doing to be administratively efficient. Slide. Just a little bit on RAND and what we've learned as we've dug deeper into the data. You've got 3 columns here looking at the relative inpatient price for RAND, the standardized price, and then the actual price in the last column. When you look at the UVM Medical Center compared to Dartmouth and the academic medical center median and average on relative price, the UVM Medical Center definitely stands out. But the key thing to understand there is the amount of Medicare patients payments that you receive impacts that ratio. So if you receive less in Medicare reimbursement than others in the sample, then that is automatically going to create a higher relative price just because of that lower reimbursement. As Judy highlighted in one of her slides, the UVM Medical Center in 23 is going to be getting or has received sole community enrolled designation. So that first column there, when you look at the relative price in future years, the UVM Medical Center is going to look very different when that higher Medicare reimbursement rate is factored in. Inpatient standard price, you can see that UVM Medical Center is pretty close to the median and the average there. And then in terms of actual price, it's actually below both the median and the average. Next slide. In terms of outpatient, this is something that we still need to do some more digging here. But what seems to be the main issue that has the Vermont and the UVM Medical Center looking like an outlier in this study appears to be the mix of services. So in Vermont, we provide a lot of the services in the hospitals. There's not a lot of outpatient surgery centers, outpatient imaging centers. So a lot of that care is provided in the hospital setting, which creates a higher price, if you will, on the RAND study, but more work to be done there. But the other key piece that we wanted to highlight with this chart here, if you look on the right-hand side, certainly the higher price on outpatient services is not due to market power because you've got critical access hospitals, small critical access hospitals that are in the same range as the UVM Medical Center. Next slide. So we've talked about this. So when you look, price is one piece of the equation. When you look at costs for patients and insurers, Dartmouth Atlas data, even though it's 2019, showed that the 3 health service areas are the lowest that we provide services to, are the lowest in the country. Next slide, Elliot. This has been substantiated by the Cooper analysis that was presented to the Green Mountain Care Board, I believe, last summer. When you look at Medicare in the chart on the bottom, Vermont is in the first quintile. When you narrow the scope down to the Burlington hospital referral area, it's at the bottom of the first quintile. And then when you look at commercial and Medicaid, as Sonny pointed out earlier, both of those are actually below the middle quintile. Next slide, Elliot. Back to you, Judy.
All right, thank you. So we are down to our closing section. On the next slide, we'll take just a minute to talk about the importance of days cash on hand and just some rating agency data here indicating 150 days is really minimum and low end of adequacy to support operations. And when we look over our days cash on hand, you can see with our loss in FY22 of nearly 23 million, that certainly did dip into our days cash on hand, and we have not fully recovered. When I think about days cash on hand, it's not just about our power to invest, but it is ensuring that we have the fortitude to continue operations for our patients and paying our employees if we were to see a significant break in reimbursement. And organizations through cyber attacks and various things have seen those. So it's an important factor to me for day-to-day operations, in addition to how rating agencies see that as the health of an organization. Next slide, please. Thank you. So FY23, we talked about, I just mentioned that FY22 had a significant loss of nearly $23 million. We did put into place at that point, carrying into FY23, carrying to 24, and even into 25, initiatives that would allow the opening of access for patients to ensure that we were meeting the needs of our patients and those that unique patients that are seeking care for services at University of Vermont Medical Center. So you can see the $80.2 million variance to the approved budget. And you can also see on this screen that 121 million is utilization. Almost 31 million is from increased GME reimbursement. So utilization and GME is what's driving it, and it's being offset actually by negative payer mix and reimbursement actual experiences. So even though we are driving higher in our utilization and net patient revenue, it certainly comes at a cost. We've talked about inflation factors. And as you look at the bottom of that, you will see those days cash on hand have still not recovered back to 2021. And as you look on into our margins over the years, we're still not exceeding 3.1% on the margin, because so much of this net patient revenue does go for cost coverage versus just investment back into people, infrastructure, and direct patient care. One thing to note on the next slide about our FY24 projection is that we did have items in there that will not recur in FY25. So if you think about what we're looking at for a margin and expense and revenue, we've got 38.8 million of items in our FY24 actual experience that will not go into FY25. But I do want you to note on the right side that even with those, the increased utilization that we mentioned earlier, we are still looking at a margin of only 3%. The next slide is just to show the trending of our margin at the bottom there from our loss all the way through our expected 3% margin for FY24 and 2.9% for FY25. So there's a lot of factors that go into our financials. And the cost of delivering care certainly has increased. And that is evident by the way the utilization has gone up, revenue has gone up, and our margin has stayed around that 3%. The final slide that we have is just the request that the Green Mountain Care Board grant our 7.91% commercial reimbursement rate increase along with the 9.3% NPR increase. And I'm going to let Dr. Leffler have the final word on our budget submission.
Thank you, Judy. So just to summarize that presentation, UVM Medical Center solely exists to serve our patients, communities, and learners. We can provide high quality, safe, expert care close to home. We're a key resource for the state of Vermont, for other hospitals in our region, and for patients across our catchment area. We're training our future caregivers, which is essential to Vermont's workforce and essential to have enough doctors, nurses, respiratory therapists, etc. in Vermont to care for us when we need it. The budget we presented will allow us to care for our patients, invest in our staff, and maintain modern, safe, current facilities. We do apologize for running a bit long. Thank you so much for letting us present.
No, thank you very much. That was very informative, and thank you for giving us the slides yesterday. Why don't we take a 10-minute break, and then we'll come back to board member questions. So we'll just come back at 10:42. Does that sound good, everyone? Okay, great. So Meg or Michelle, we can go off the record until 10:42. Thanks.
We're off the record.
I had to switch my computing system. Can everyone still hear me?
Yes.
Dr.
No,
Eppman?
it kicked me out. I don't know what that was about.
Oh.
But it happens. At least it was on a break.
There's a
I got
fair
you,
chance it's-
Owen. I got you. Thank you.
All right, there's a fair chance I did that to you by accident somehow, Michelle.
Okay.
Okay. It's 10:45. Thanks for the additional time for the little break to get this right. Let's go back on the record.
Okay, we're back on the record.
We'll turn to board questions. I think a lot of people have a number of them. I'll start. Sometimes when we do these, we focus on areas that we're inquisitive about and want to learn, so there's an opportunity to support the budget. Before we start, that doesn't mean that we don't acknowledge and appreciate many of the good efforts that UVM is making. It's just that we want to make sure we have the information we need to evaluate the request. So I appreciate a lot about the primary care support work that you're doing, the fast pass, the e-consults. There's a lot there that was very important to us, and also the reductions in administrative costs. I'm not going to focus on those because I understand them and I appreciated them. I want to start with asking about the cost shift. On page 12 of the narrative, it indicates that the commercial budget request is premised on the cost shift. Could somebody briefly describe that for me?
Judy, do you want to take that?
Can you display the information which you are referencing?
I cannot. It's page 12 of the narrative. I think it was in the presentation that the way you determined the amount of commercial was based on the other payers' reimbursements.
Certainly. I'll give a high level and then I'll ask Rick Vincent also to chime in on this. So in essence, you're looking at what is the cost to care for our patients, what revenue coverage is needed for that. There are certain payers that are set. We know what our Medicare.
Judy, I'm sorry. Can you, as I'm just going to flip through the slide so can you just identify the page number that we're talking to so everyone can pay attention to it so they'd really know what you're or if, Owen, if you have it, I'll take either one's page number on that to look at. Or see anyone that has it. I just want to make sure that we're all talking about the same thing and just to ensure that.
I forget what slide it was in your presentation. I don't know, we need a reference. My only question is, you said that you budgeted in your presentation based on the cost shift, and I want to understand what you mean by that exactly.
So again, as I was stating, although I don't see it on this one, there are factors that we know when we go into our budget based upon the time at that moment in time. So we factor in what is our Medicare improvement, what is it going to look like with our community hospital reimbursement, any other factors that we are aware of that goes into our coverage of costs. What is happening with our GME dollars? What is happening with Medicaid? All of those are factored in once we understand what the cost of care will be to deliver the expected utilization for our patients. So that is a high level. You can see here, that's exactly what I'm talking about is the Medicare rate comes out, any Medicaid rate, any other payer changes, any other initiatives that we have. We attempt to factor those in before we calculate the necessary commercial rate.
Okay.
So it's a blend of what we know at this moment in time and risk areas in terms of initiatives that we have put in.
Okay, that's what I had understood. And this is great. Thanks for pulling it up on page 12. So you've budgeted a Medicare rate increase of $7.2 million. And because that's insufficient to cover the amount of inflation together with these other factors on page 12, there's a need for this level of commercial rate that you've put in your budget submission to the care board, correct?
Yes. Once you factor in, again, all those in which we feel like we have some influence on, that is correct.
Okay. And if the Medicare rate increase were larger, would your commercial rate request be smaller?
I think any of these elements that could be adjusted, Medicare, Medicaid, any additional funding that we could receive would certainly assist in how much needs to be covered by commercial. When we demonstrated in our presentation the gap from our Medicare coverage, we do see that getting better with the granting of our sole community hospital status. But you also saw the gap in the wage index that we're experiencing.
Very, very helpful. The Medicare rate increase is $7.2 million. What is that based on?
It is based upon, Rick, you want to speak to that? Because it not only applies for us, it also applies for all of our health network partners.
So it's based on the estimate that we had at that point in time, Chair Owen, when we submitted the budget that Medicare put out back in, I think, April or May.
And what percent was that?
I will pull that up if you want to continue with the next one.
Was it? I'm gonna guess it was 2-3%ish. Is that about right?
Yeah, we want to make sure we're quoting the right number. So if you give us just a minute to make sure we've got that.
We can come back to that. I want to make sure we
Okay.
stay on schedule as much as we can.
Thank you.
And then you have Medicaid for $8,508. What's that based on?
Again, the same basis in terms of information we receive regarding any potential rate increases. So you can see Medicaid is basically flat to no rate increase.
And then to put together the fiscal year 25 budget, you took the fiscal year 24 budget and then applied these inflationary factors for the total dollar amount requested?
We actually took what we are experiencing in FY24. So the cost that we have in place to deliver the care of the higher utilization, then the inflation factor goes on that. So I do think that it's important to note that FY24 was the budget that we had and based upon what we knew early on at that point in time. But as you've seen in our slide representations today, the utilization has exceeded that, and the costs associated with that also have exceeded that expectation that was built into the FY24 budget. So I want to be clear that our FY25 does take into consideration the real experience that we're having when we submitted this budget.
Okay. So it's a fiscal year 24 projected to a fiscal year 25 budget.
Yes.
And the overage in NPR from fiscal year 23, that is, I don't know if the term's right, but baked into this budget?
23 utilization did go into FY24 as much as we knew at that time. But the demand for services at University of Vermont Medical Center, as you saw with the increase in the new unique patients, is in this FY25 budget, because those are patients that are currently in our utilization and care numbers.
Okay, so this budget presumes the fiscal year 23 NPR overage. This includes that money, and then it includes whatever you're experiencing in fiscal year 24.
Each year is represented based upon the time in which we're preparing the budget, what that current experience is. So we're not going back to 23 and saying, adding 23 to 24 to 25. We're not compounding. We're really
understand.
looking at the moment in time and saying, what does utilization look like? What we want to make sure you understand is, you as the board understand, is that that need for services at the academic medical center has been growing.
And you do not, UVM Medical Center does not do zero-based budgeting, is that correct?
In so much as we have fixed contracts and we have fixed patient care ratios, you cannot take those back to zero, because we would not be able to do that with our current contracted requirements. And again, patient safety. So we do not start from zero. We do start from, what are we experiencing now? It's not just an add-on to building on top of that. We do look department by department in terms of our metrics. We use a metric-driven budget that relates volume to expense. And we also look for factors and areas in which we can create economies of scale. We can get reductions in costs through our supply chain negotiations, and other areas in which we can actually have additional revenue come in that relieves some of the burden on Vermonters.
Do you subtract out any one-time expenses that are incurred in the prior year?
So in the slide that I showed on the FY24, the one time, because those will not come in to FY25, that was $38.8 million of one-time assistance. That does not carry forward into FY25. The same thing with expenses. So any one-time expense, area by area, is gone through and scrubbed for any one-time expense to make sure that those are not carried forward.
Was that in your slide deck?
The expense component or the one-time revenue?
Expense.
No, it is part of our working papers when we prepare each department's budget.
Do we have an analysis of the variance of one-time expenses to fiscal year 25 budget? Let me ask it another way. Do we have any records indicating what one-time expenses were taken out for the fiscal year 25 budget?
I am not aware that we have submitted anything, and I would open it up for anyone who has been sworn in or can provide testimony if we have.
No, Judy, I don't believe we were asked to present any one-time expenses that have been removed from the budget.
All right, there's always follow-up. I'll put that on our list for follow-up for our staff to send you a letter requesting that.
Certainly.
All right, thanks. So what's the basis that the care board should look to that the base expense on which UVMMC adds inflation is appropriate and necessitates coverage by commercial?
I think we've presented in multiple documents that it is in relation to our utilization of services to deliver care for our patients. So if you look at what the utilization and demand for services has been, when we're building our expense budget, we look at what is that relationship now, less any one-time revenue or expense items, less any ability we have to lower cost in any of our expense categories. And then we look at other contracts with our various union partners and factor in those increases into our final rate. So the inflation is based upon those categories of what we are looking at a granular basis of, does this move with volume? Is this a fixed cost that will not be adjusted? And we actually have indicators in our budget build that tells which ones fluctuate with our volumes and which ones do not. So it is not applied to every expense category. So to answer your question, and I will also offer it for anyone else to add, when you look at the basis for our budget, it really is about delivering care. Are we seeing an increase in access for the patients that are demanding and needing services for the University of Vermont Medical Center, where we are either the provider of choice or the only provider to deliver that? And what are the expenses related to that to deliver that care?
Maybe just to add to that response, Chair Foster. So in the presentation we just gave, starting on slide 38 through most of that next section, pretty much through, I'd say through slide 48. That's where we've attempted to provide evidence in terms of that cost base that the cost inflation is added onto. I would just add as well that cost inflation, we're not necessarily looking for commercial rates to cover that. We're looking for rates generally to cover that cost inflation. So I think the question that you were asking would, if Medicare or Medicaid, if their rates went up, would that impact commercial rates? Absolutely. And so it's rates more generally that we need to cover cost inflation.
And not just rates though, right? Like if you had more GME money, that would contribute as well. I think you did that. Is that correct?
Which is really it's a rate increase. So when you look at those categories, and we're happy to kind of walk through those in a little bit more detail, because I know we went through that slide pretty quickly, but even you see a line on there that is patient placement and length of stay opportunities. We wanted to be transparent there that because we have seen improvements where our length of stay has gone down, which means, just using a simple example, let's say you have 400 patients in the hospital. 50 of those patients we're not receiving any reimbursement for because they've exhausted their DRG payment. If you go from 50 patients that you're not getting reimbursed for down to 30, that essentially is a rate increase. You're collecting more per unit than what you were collecting before, and so that's why you see a line there on our commercial rate calculation for that as well, being transparent that truly is that's a rate increase that should come out of the mix, because we'll end up seeing that.
Okay. And you gave some information on this, but do you have a sense of how Vermont commercial insurance costs today compared to national?
I don't know if anybody else has that's been sworn in has a sense.
I would not feel comfortable testifying as an expert in that area.
As a executive at the University of Vermont Medical Center, not necessarily an expert, do you have a sense? And if you don't, that's fine, but I want to get it to the extent you have one.
I think we've talked about on past occasions about the proportion of patients that are insured commercially versus Medicare and Medicaid. That's always going to have an impact on rates. So it's generically, you would have to look at that payer mix in other states to see how the commercial rate for the patients in those areas is impacted as compared to Vermont, as well as any particular incentives that states provide. So I would say that it is a complicated component, and I would not be able to offer that information. But I think it's a good question.
Do you think the Green Mountain Care Board should consider how expensive commercial insurance is to Vermonters in evaluating your budget requests?
So Chair Foster, I think the Green Mountain Care Board should consider everything that goes into setting our rates in our NPR. We presented a budget that's the budget we believe we need to take care of Vermonters who need our services. And we've shown you that we're trying to use every dollar at our disposal to do that work. And so as our regulator, which we understand, we believe you take everything into consideration when you make decisions around the rates that we're going to get and our NPR total.
So this is the struggle of a regulator,
Sure.
the need and the ability to pay for it, and the impact of the cost. And so my question is very narrow, which is whether you agree or disagree that the Care Board should consider how expensive commercial insurance is in evaluating the fiscal year 25 budget submission.
Chair Foster, maybe I would say if we could pull up slide 36 on a pretty simplified maybe way of thinking about what we're asking for and why. And so I think as a regulator, I guess the ask here would be, if you see anything on here that you believe either we or other organizations that you have influence over can have an impact on, and whether that causes it to go up or down, or you disagree, I think that would be the way that you should influence it. So for example, you look at, we believe the Medicare rate increase is going to be 7.3 million. If you have insight that it's only going to be 6.3 million, you should tell us that. And because that you should correct us, and you could say, gosh, it's going to even be more expensive than you think. And if you think we believe that your length of stay reductions could be greater than that because of A, B, and C and the evidence to point to that. And so you ought to be able to cover 15 million of, right? Any component that you believe that has an impact, I think that you can influence, I think that is really powerful. So to come back to your question, so all those factors, any factor that you think that we can influence or you can influence in other ways, or you can influence with the state, all of those matter. And I think they're important. I don't know. I think if we have good information about what contributes to that commercial rate or other ways to influence that, then we ought to all be working together, you as our regulator leading us, but working collaboratively with us to do that. So if we have an opportunity to get greater IGT, and that would influence the rates and decrease the cost to Vermonters for commercial insurance, let's work together. I mean, right? Every piece of that is really important. If again, you can look at this and you have to kind of agree or disagree with the overall principle and go through it. If you say, I think it's not affordable for Vermonters, and so we're going to reduce the rate, I would say, I don't know what levers can we pull to continue to be delivering care based on the data that you've seen, and then we ought to have that conversation as well. So, I mean, I guess everything, I'll summarize, I'll end by saying everything that we're trying to put in to our budget is trying to bring the costs down as much as we possibly can, while trying to deliver the care that we believe our patients deserve and they need. So that, I guess that, I hope that answers it.
To Chair Foster.
Let me interrupt, because I just want like a precise answer on the exact question, and I'm just going to make sure I get the answer because I think it's helpful and important. So one, Dr. Eppen, I agree. There's many things on this slide 36, I think it is, that the Care Board doesn't regulate. We don't regulate Medicare rates, Medicaid rates. We don't. These aren't our bailiwick, and that's not part of our regulatory process other than reviewing it in this process. And I'm happy to lend my voice that some of those reimbursements should be quite a bit higher. I think some of that is without a doubt. But in this regulatory process, I have an obligation to look at your costs, and even if they're legitimate, to consider the impact on Vermonters. And I'm not just your regulator, I'm the state's regulator and the people's regulator. And so my question is very narrow. Whether you, UVM Medical Center, believe the Green Mountain Care Board should consider how expensive commercial insurance is to Vermonters in evaluating this request.
Yes.
Just as much as you should consider every other component of what's in here. Yes.
Of course, there's many different factors that go into our statutory obligation to review your budget.
I might add one other point. And Elliot, I don't know if you can pull up slide 20, I believe. So just highlight that that yes, affordability and commercial rates should be factored in, but there are other things that that we can do together between the Green Mountain Care Board, AHS, other stakeholders to make care affordable. So commercial rate is only one part of the puzzle here in terms of addressing affordability, and hopefully there are ways that we can work together to address that. There are things that potentially that we can do as a state in terms of the economy, job growth. There are multiple components to this that I would just add that commercial rates is not the only piece of the puzzle in terms of affordability.
Very, very fair point. Very, very aware of that. And it's an important point that there's so many components to this. I've said it publicly, our healthcare system is fundamentally broken and we need to fix that. And I think that would help with some of your costs. I've spoken publicly many times about the demographics and the housing, and I think some of that shows up in your costs and expenses. There are many, many factors, and I'm not ignorant of those by any stretch if you look at anything I've said publicly in the last year. One question I had on this point of the cost shift and these, I think you called it a lack of adequate reimbursement from these government payers. Why should commercially insured Vermonters pick that up?
I'll take one shot at it. It's because that's the way Vermont has decided that they want to pay for healthcare. There are other ways to do it, certainly if legislatively they made determinations. So for example, if we decided we didn't want to pay for equitable care across all of Vermont, that'd be one way you could reduce the cost to commercial payers. You could also say we're going to increase taxes on dividends that get paid to Vermont residents as a way of compensating for the total cost of care that we want to provide. And so that would decrease the commercial rate. My understanding, and lots of people with greater history here, my understanding is that legislatively, this is the way that we decided as a state that this is the way we want to pay for the cost of delivering care equitably to all of Vermont. That's my understanding, but please, Steve, you might have better insight into this.
I would say it a little differently. I would say if you look at Vermont, about a third of Vermonters have Medicaid. In general, Medicaid benefits in Vermont are pretty rich. A third of Vermonters have Medicare. We've shown you, I think you agree with us, that we're three of the lowest Medicare expense counties in the United States. And about a third, a little less than a third of Vermonters have commercial. Oh, and you and I, or Chair Foster, you and I have just discussed recently that our Vermont insured population, commercial insured, is older and sicker, high utilization rates. Vermont as a state over many years, I would say not purposefully, but made a lot of little decisions that have put a lot of pressure on commercial insurance. How we distribute Medicaid dollars, what the provider tax rate is, what dollars we draw down from federal payments, how we use a lot of different things have put pressure on commercial. Now we're in the situation where we're trying to deliver care to Vermonters who need it. We're building a budget to do that work to make sure that we have what's necessary here in Vermont to provide academic tertiary care to Vermonters who need it. And the way we build that budget is the way we submitted it. The cost inflation that we see in 25 needs to be covered somehow. We have to be able to cover the cost of the people who work here, the equipment, pharmaceuticals, et cetera, that we need. That's how we've been building the budget. I also want to reflect on what Dr. Epen and Rick just said. I do strongly believe in Vermont. If as a state, we work together to take pressure off commercially insured Vermonters, as a state, we could do it. It will take all of us, the healthcare system, absolutely, our regulator, the legislature. We could do a number of steps differently that would take pressure off. But right now, the system that we've built through lots of little decisions over a long period of time is how we're building our budgets to provide that care.
Certainly a much, much bigger conversation. And I do not agree with financing healthcare this way and the pain that it's inflicting on commercially insured Vermonters and the corresponding negative health impacts that this has. So broader conversation on what we can do and the policy decisions that can be implemented. And I look forward to working with you on that. Have you spoken with Medicaid or the legislature for fiscal year, I guess it'd be fiscal year 24 state budget on increasing the rates for Medicaid funding?
I don't think we swore in Jason, and I'm not clear what kind of conversations happened there. We will get that to you.
No one here testifying was party or aware of any conversations? And I understand it doesn't mean they didn't happen, but just you folks.
Yep, I can tell you that I've certainly talked to representatives from AHS. I've definitely talked to legislators talking about the fact that we don't have adequate resources to cover the care, number one, that we want to deliver and patients deserve, and number two, that Medicaid and Medicare don't cover those costs, and that our current state of affairs are that the commercial payers are the ones that have to foot that bill. And we understand the burden, and we need to work together to figure out a different way to do it. So I've definitely had those conversations with all those representatives that I've mentioned.
And can you give me a sense of what the response was? So you essentially said we need more money from Medicaid. What was the response?
No,
I asked for two reasons. One, I want to know, and two, I want to know whether there's an opportunity still to alleviate some of this commercial burden.
Yeah, I guess I phrased it a little bit differently. I said that is one place where we definitely could use more, but there are many places that we could do this differently to take the burden off of commercial payers. So one is to advocate for greater amounts of funds from Medicare for the services that we provide. That would go a long way as well. We could think about how do we create more, and this is very specific, but you asked it, I'm telling you, how do we create more mental health beds and post-acute beds in the state with state funding to help take care of Vermonters, which is the right thing to do for Vermonters? That would relieve an enormous burden from us to be able to do that. Three, how do we use the existing post-acute beds that are there? And can the state help us to fund everyone that has a nursing home bed, everyone that has home health and hospice care? If we can better fund those so we could provide more care out of the hospital that does not need to be in the hospital, that would reduce our costs without changing those. We can talk about, I mean, there are many, many ways to do this to go to that.
Sorry.
Yeah.
Let me just refocus. My fault. I diverged a little bit. That's an important conversation, but I want to make sure we're respectful of everyone's time again. Ms. Longinus, I prepared some documents, a slide set. Could you put that up, please? I was intending to make this fluid and easier to see what I'm referencing. So you can go to slide 2. And I forget what slide it was, but let me have it here. Slide 42 from your presentation indicated the Medicare cost coverage was 75% in 2022. And I just want to reconcile that with the submission from the outpatient surgery center that the Care Board recently reviewed, where the 2023 number you provided said 67% of cost of care was covered by Medicare. Am I mixing things up, or can you help me understand that?
So I can maybe take a stab at that, Judy. If in this this is just an assumption that Chair Foster, so we'll follow up just to validate that that's the case. I believe, so on slide 42, we're talking about cost report coverage on that slide. This here, I believe, is our internal cost and decision reporting system cost coverage. So I think it's two different data sets, but we will validate that for you and follow up.
Okay, yeah, so this one, the one that you submitted in the outpatient surgery center says 67%, and slide 42 from this morning says 80%, so a 13% difference for fiscal year 23, which is pretty significant.
Yeah, we can get the detail of that. The slides that I presented were focused on a couple of components of Medicare reimbursement, and also looking at how that compared to the information the Green Mountain Care Board had received regarding overall. I do not know if this particular cost coverage slide is more specific in area of coverage, so we would need to follow up with the details behind this.
So is my slide that I'm showing you in slide 2, that's a UVM self-calculated number, is that right? Internally generated number?
It also looks like it's directly to the OSC, so it might be for care, and I'm not certain of this, Chair Foster, but when I'm reading the line, it says for the OSC, the cost coverage would be this, whereas slide 42, I think, is for all services we provide.
Well, no, it says, you say in the submission here that the cost coverage will be close to that reliably measured across the UVM Medical Center. Next sentence, quote, those cost coverage percentages are as follows, taken from the UVM Medical Center fiscal year 23 actual financial results. So not just the OSC. You're projecting
Yes.
the UVM Medical Center across the board cost coverage to the OSC.
Yeah, so I think, so Chair Foster, just we want to validate that that's the case, but this number here is our internal reporting, and on slide 42 is the NASHB reporting that, so two different sources, but we'll validate that for you. And,
All right,
and get
which
back to
one do you think is more reliable and I should rely on?
So our internal data we feel is more reliable.
Okay.
So
Then why didn't you present that in slide 42?
Because
Because
we were
we are-
responding to the NASHB
Sorry.
data and wanted to, sorry, go ahead, Judy.
No, that's exactly what I was going to say. Thank you. It was to basically try to interpret and distill the NASHB data and what we're seeing with that limited lens and with only the items that are allowable in the cost report. A P&L takes into consideration all costs. The Medicare cost report doesn't have every cost as an allowable cost. So there is a variance between what your P&L statement has and what your cost report has because of the allowable and unallowable items in Medicare cost report, in which I won't even attempt to go down to that level of detail, but they are most of the time significantly different in what coverage you would see through your P&L versus your cost report.
Okay. And under your internal calculations of cost coverage, are you projecting those to improve in fiscal year 25 from 67%? And if so, to what amount?
I have not recalculated this particular component myself. I will say that we factor in all payment improvements when we build our budgets.
So that would be helpful, just because to me, I got two different numbers around the same thing. Understanding how you made your internal calculation, I think I could probably guess, but I want to be sure.
Yeah, I
all right.
think Chair Foster, I think it is really important to really, I mean, because it looks so different, I think it is different. I think it's really important to identify the really clear differences before you draw any conclusions. I mean, for example, and I'm far from a NASHP expert, but are professional services included, for example, in the NASHP data? I just don't know, as a very small example of what that would be and what a difference it could be. But I think we can't compare these two without really understanding all the components of it, but we know that they're clearly different.
Sure. Okay, thanks. Kristen, can you go to slide 4? So this is some information the hospital submitted relating to the fiscal year 23 overages. The document, I think, was called Bridges, and this shows the differences, the variance from budget to approved. And I just want to understand a couple of these. So first, the GME money, $30 million. When did you apply for this additional money?
So this is 23, so this would have been, and it's not that we applied, it's that the calculation for how the GME arrangement was calculated, was updated. So for years, there was a limit of $30 million on that GME arrangement, which actually was an arbitrary limit, which in the updated calculation was allowed to actually calculate as it is in other GME arrangements. So this is supposed to replicate on the professional side for the majority of it. What would you get paid by Medicaid if those were equivalent to commercial rates? And so that calculation was updated in 23, which you see. That's why you see the large increase there, where that $30 million cap was removed.
When was that updated?
Again, it would have been updated sometime we would have had discussions in FY23, but it was reflected in the FY20 or FY22. It was reflected in the FY23 budget.
Okay. Yeah, that'll be a follow-up. When those discussions occurred and when the determination was made that it would be updated. The timing of it is what I'm trying to get at. And I wasn't here at the care board at the time, but it's my understanding that there had previously been an under budgeting of GME money, I think also for fiscal year 23. Do you recall that?
Yeah, I don't recall that, no.
I think go to slide 5, Kristen. So this is our budget order, the little paragraph I pulled out of our budget order, and it indicates that UVM's budget submission for fiscal year 3 didn't include an additional 11.9 million that, subject to approval, is expected. And so is this 11.9, the reason that was left out of the fiscal year 23 budget, the same as this additional 30 million, or is it different?
In preparation for the 23 budget, I'm not aware of any purposeful removal of additional funding. So we would have to look into this.
My question, my question's not, was it purposeful? My question was if the reason I'm trying to understand why this 11 million wasn't in.
We'll have to get that to you, Chair Foster. I can't recall exactly when and how we learned about those dollars.
Thank you.
So we'll follow up with a response on that.
Kristen, can you go back to 4? The utilization increase, this indicates there's $121 million in additional utilization. Was there anything unique about the increased utilization that targeted commercial payers or government payers? Or was it kind of consistent across the board?
We took care of everyone who needed our services. So 23 is the first year after the pandemic. There was a lot of people who delayed care. There was a lot of pent-up demand. We ran a lot of programs to try to catch up on people who are waiting for procedures and so on. We did a bunch of surgical sprints. It was not targeted to any one group. It was everyone who needed our services.
Great. And do you have a sense of whether it was fairly consistent, the increase in utilization across payer type?
I do not know that. I do not know, although I can tell you that we ran sprints, for example, in cardiac surgery, which is much more likely to take care of a lot of Medicare patients. We ran sprints in total joints, which was probably a mixture. We ran sprints in catching up on pediatric dental, which is almost certainly all Medicaid or no pay. So we ran sprints where people needed services.
If you can, as a follow-up, provide the breakdown of where those increases in utilization were by payer, that would be very helpful. Then on the reimbursement payer mix, it was $75 million below budget. Can you break down how much of that 75 million was based on reimbursement versus payer mix?
Yes, we will. We'll follow up with providing a response on that.
And for the payer mix, I am fairly new to being a regulator still. I feel like you probably always feel new as a regulator in some ways. But the payer mix really means if you're losing money, you had more people going on government payers than commercial than you had budgeted. Is that right?
So the expectation for the payer mix is based upon the prior experience. And during FY23 or any fiscal year, when you see a different experience, whether it is moving from traditional Medicare to Medicare Advantage, or patients moving from Medicaid to self-pay, those are all in the actual experience, and we can provide that breakdown.
Right. Okay. And those shifts can cause the medical center to lose money because you're getting reimbursed more if those shifts go to the lower paying entities.
So not all NPR covers cost. So yes, it's not only a matter of losing money, it's the inability to cover cost.
Understood. Okay. And then reimbursement, by that, I assume what you mean is how much you're getting. You budget an amount that you'll get paid back, and there's some that you have negotiation or things happen where you don't get all the money you had billed. Is that what that means?
Yes, reimbursement has multiple factors, but some of those can be based upon the expectation of a particular payment rate that comes in different from what we budgeted. We should
Right.
also have the breakout of that we can provide.
Okay. Understood. That's helpful. Bad debt and free care. And what I'm taking this to mean is that the amount that you thought you'd budgeted for bad debt and free care ended up being a lot less than was actually provided in bad debt or free care. Or sorry, experienced in bad debt and provided in free care.
What flowed through our P&L was lower than our budgeted expectations. I do want to say it's important about the timing. So what flowed through in FY23 isn't just about FY23 volumes and charges. And bad debt free care, because of the length of time for billing and the time it takes to apply for financial assistance, those are significantly delayed. And we are doing our best to make an estimate of what the approximate amount is, but you may see it be higher in some years than other years because it's not based just on what occurs in FY23. So it's usually put together as an estimate and based upon what we have in different payer groups and what might likely flow through. But the actual experience is what you're seeing here that you'll also see is different in 24.
Is that the same for free care?
Yes.
Okay. So for
and again, free care, I like to call it more of assisted care because you can receive anything from a percentage discount all the way to full forgiveness of any type of medical debt. But they do take quite a while to process, and there's significant amount of work to ensure that all of the information necessary to process those is in place.
Okay. So for free care in 2023, the medical center budgeted 25 million, and in actual free care, it provided 18 million, a difference of $6.8 million. And are you suggesting that some of this $6.8 million may actually have been provided, but it just isn't showing up in fiscal year 23?
Correct. The care may occur, the care may be delivered in one fiscal year. And the flowing through the P&L, whether it hits bad debt or free care, may end up in a different fiscal year.
And how much did you budget at UVM Medical Center for free care in fiscal year 25?
I'll pull that.
And then historically, let's just take years 21, 22, 23, and 24. Is there any, I guess I might just put it as a follow-up that I'd like to see what was budgeted and what was actual for those periods of time, because I want to see how this is playing out. Because if you're under on one, you should be over later if this temporal aspect, there should be something to see there. So I appreciate that.
Certainly,
The
we
next,
can follow up with a response to that.
thank you. The next column is administrative write-offs, which is 17.9. What are administrative write-offs?
There's a multitude of things that go into it, from service recovery, that we would provide a full or partial write-off for a service. Also in that are denials.
Okay, those are separate from the reimbursement category?
We'll get you the breakout of what falls into administrative write-offs and how that flows through, as well as what's in our reimbursement and payer mix component.
Okay. And how much was budgeted for fiscal year 23 in write-offs? This says UVM had experienced 18 million more. How much was budgeted?
I'd have to do the calculation or pull our FY 23 financials, because you can see that looks like it was over budget by 1.1%. But I do not have the exact number in front of me.
Yeah, fair enough. That helps. And same follow-up is I'd like to see this over time, how it's played out, if it's consistent with budget, over budget, under budget. The next exhibit 6, Kristen, please. Then this is the fiscal year 23 bridges document for expenses. What was the amount of the Medicaid ACO shared loss? That's not on this, but it was in a different document you gave us.
We'll have to pull that and look, unless Rick, you have it pulled up.
No, is there a chart that maybe we can pull up there? Is this in the same presentation of the staff?
I apologize. I didn't put. I have the screenshot in my notes, and I can read it to you if that helps. It's from a different document, or I don't know what document it's from actually. But quote, a significant offset to the above favorability, that I think is the other page, was due to the unfavorable gross payer mix, Medicaid ACO shared loss, unfavorable collection rate to budget, and additional dish payment that did not materialize compared to budget. Close quote. So I'm kind of guessing. I think this paragraph that I just read was under the previous exhibit. But I didn't see that ACO shared loss in this bridges document.
It would be helpful if we could just see that, and if you could have the staff just point us to that, we'll definitely provide you the detail on that.
Right. They're overworked and underpaid, so I'll do that one myself. And just making sure I'm reading this correctly, on salaries, UVM Medical Center paid 25.6 million less than it had budgeted on salaries.
That is correct, because if you look at the next line on contract staffing, unfortunately, we were not able to actually fill with our own staff or recruit additional needed staff. So you can see the contract staffing on the next line. And both of those go into factoring, what is needed to care for the patients.
Right. And then when you say salaries and contract staffing, are these numbers specific to nurses?
I would have to look at the specificity on the makeup of the 25.9 and the 43.5. The majority of our contract staffing has historically been nurses, but it's not all.
Okay, but later on it says negative $7.5 million for physician contracts. So the staffing line doesn't include physicians, right?
No, so the physician contracts, so locum tenens is the equivalent of contract staffing for physicians. So what the chart is showing there is physician salaries similar to staff salaries, which is that first line. We're both under budget because we had fewer employed people, but the contract, we had to hire contract staff for both staffing for regular staff and for physicians.
Right, great. That's how I read it. In terms of the staffing and nurses, the physicians and nurses. And do you have a breakdown of the service lines where those contract staff and locum tenens were utilized?
Not by service line, but by service area, whether it be inpatient, outpatient. We have, and when I say outpatient, it would be specific to, are we using it for radiology? Are we using nurses? We have that type of breakout.
Okay, that would be helpful for this. Going to drugs, this means that the medical center spent approximately nearly $30 million above budget to purchase drugs. And are these drugs that are hospital administered drugs, pharmacy drugs, drugs provided during the course of procedures?
I believe we have a couple of people on who have more of the detail on this in terms of how it's categorized. So I'm going to ask Peter McDonald and Mark Stanislaus to speak to our drug line as it converts from our P&L over to these numbers in terms of what is in that.
My understanding on this is this includes all the drugs that are used. It includes both inpatient, outpatient drugs and outpatient along with, so there's an inpatient breakout and then there's retail pharmacy, and those are both included in this number. And Mark, I don't know if you have a different on that.
No, that's exactly it. So there's the retail pharmacy that those dollars to fund come through other revenue. And there's the direct drugs that are provided to the patients related to their care that they're receiving. We can provide that breakout of that 29.9 million between those two items, Chair Foster.
Okay. And then those inpatient, outpatient, and retail pharmacy drugs, does UVM add a markup to what it's paying on those drugs? Sorry, what it's paying for those drugs?
In distributing to our inpatients, our outpatients, is that what you're asking? We have charge masters for everything that we utilize. Because I
Right.
understand that the price of anything, whether it is anything that is utilized in the care delivery, also takes humans, technology, those. So there are direct costs that certainly have to be covered.
And are the markups limited to those?
Limited to those, I'm sorry.
Yeah, you just described a couple expenses that go into providing, handing somebody at the pharmacy the drug, employing the pharmacist, having the, all the equipment needed to deliver the drugs. Are the markups that you charge to insurers limited to the cost to furnish the products?
There is processes for charge master pricing that occur across the nation that takes in multiple factors of cost to deliver care. It also flows through our P&L in terms of the expense of those items. So I do not have a specific in and out type of listing that I can provide you for what is included in the cost of each drug. It is a methodology that is used on pricing in our charge master that looks at the cost of delivering care, the cost of that particular, whether it be an implant or a pharmaceutical drug, that does seek to cover costs for providing that. And we also take into consideration what is reimbursement. So there's several factors that go in. So I apologize. I cannot just give a yes or no
Yeah.
response.
Understand. And the amounts that you are paid by insurance companies, let's just take a retail pharmacy drug, that's negotiated between UVM Medical Center and various insurers. Is that right?
Rick, I see you've unmuted. So I don't want you to think that it is specific to each and every drug that we have. We do not negotiate every single drug or supply item. So Rick, do you want to speak as well?
Yeah, actually, I was going to maybe have Kaylee Chapney, who we did swear in, just because I don't want to. There is a difference in terms of how we contract for patient revenue versus specialty pharmacy, and I just want to. I don't want to misspeak because there's two different ways that we do that. So Kelly, I don't know if you can add any clarity between those two.
Sure, I'll take a stab in. Chair Foster, so first, the expenses that are here are drug purchasing price, which I think this conversation is blended to the charge. So just wanted to differentiate what's here is that, how much we purchase the drug that we have to then use. And our contracts with our payers do have a variety of terms. If it's what they call the hospital-based, inpatient or outpatient drug, we do negotiate the rates with the payers. If it's through our retail pharmacy, that is actually outside of my purview, and that's negotiated with PBM, so that is different. So our payer contracts do not encompass the retail pharmacy. I just want to make that clarification, but they do have rates that cover the drugs we know, and then sometimes in the specialty, for example, in CAR-T, we work collaboratively with our payers to get appropriate reimbursement, especially for those higher cost drugs.
Great, very helpful. And in connection with the negotiations with the insurers on those hospital-based drugs, do you consider, let me ask another way. For the negotiations for the hospital-based drugs that you negotiate with the insurers, do you treat the care board orders on budget as part of that negotiation? i.e., do you limit the increases based on the care board budget orders?
Our rates in aggregate include the hospital-based drugs, so they are included in the aggregate commercial lift that you approve. Yes.
Great. Okay. All right.
Chair Foster?
Yeah.
I just want to come back to your original question, and I want to make sure that we got it. So what you're seeing here in this 29 million is what it cost us to purchase the drug. It's our cost, and it was 1.6% higher than we expected. And you can imagine, I think, that if volume went up, then we spent more to buy the drugs, and that would drive the cost up, right? It's the total cost. And please correct me if I just wanted to go back to your original question because we wandered way off of it. But if someone can just validate what I said is true, my understanding is that we spent 1.6% more is what it cost us. Our cost for the drugs went up by that much for all these variety of reasons. It could have been that pharmaceutical companies increased the cost. It could have been that we actually used more of the drug because we had more patients that year that came in for something, right? Will someone just validate that for me?
That is correct. Yes,
Okay.
That is correct, Sonny. Thank you for bringing us back on that.
Let me I want to keep going. I think the record's really clear on that, and a helpful clarification, but I got that. And I appreciate that. On the other category, the 16 million, what's that?
All right.
Judy,
I know we have. Go ahead.
No, I was hoping you were going to answer. Do you know what's in the other category, the next to the last line?
So I'm going to actually ask Mark Stanislaus and Peter McDonald again to weigh in on this because it's a conversion from our detail into the large category that we have here.
And it's
There's
okay.
no quick and easy answer. Yeah, there's no quick and easy answer. I mean, basically that is the variance of everything else. So there's a lot of different small contributors, plus and minus, that could flow into that.
And purchase services, actually, Mr. Stanislaus, let me ask another way. Is there any of the 16 million, do you have a sense of what the largest contributor might be?
We'll have to look at the detail, Chair Foster, and get that back to you. There's just so many contributors. I just don't want to misspeak.
Appreciate that. Purchase services, 13 million. That's consultants, lawyers, that type of thing.
It also includes temporary, a piece of temporary staff that isn't in contract staffing. So there are some consultants too that are not providing advice. They're actually hired to do a specific task for us. So it's a combination of all those things.
What type of task?
So we might use a consultant to augment our IT staffing. If we've got a project and we don't have enough internal resources, we'll hire them to do some additional work.
See, okay. And then provider tax, that was favorable by $8.5 million. When did that come about?
Well, provider tax is calculated on a monthly basis based upon the estimate of the revenue that would be applicable to provider tax.
But your revenue was over significantly, so why would the provider tax be less than budgeted?
So we will look at the detail for that. Go ahead, Peter.
Yeah, there was an adjustment made in July. We did a reconciliation on the liability and we were over accruing for that. So that's where the adjustment, and that's why that number does not tie out or match up with the net revenue.
I see. And thank you for that. The reconciliation was on liability for when?
I don't know the time period, but we can get that to you.
Do you know whether it was for fiscal year 23?
I'm not sure if it was just for 23 or if it included more than just 23. So we can get that to you.
Okay. All right. And in your presentation, you spoke about the Seoul Community Hospital designation, which I appreciate hearing about. My understanding is that UVMMC gets a 7.1% increase in payment from Medicare in connection with that designation. Is that right?
Yes, that is correct.
Is there any increase in payment from the rural hospital status that you changed to?
I would have to look and see what financial impact that would have. I do know the Medicare one was the significant impact.
Okay, let's have that as a follow-up to check on that because I didn't see that. Doesn't mean you didn't give it, but I didn't catch it. So the rural hospital designation, if there's a bump, let us know. For fiscal year 23, the Seoul Community Hospital equated to 9.5 million. Do I have that right?
Where are you referencing the number just so I can validate it? I don't want to rely upon my memory.
Yeah, you and me both. I don't recall exactly where I pulled it from.
We can validate it for you, though.
Oh, no, here it is. It's on page, you guys, the medical center submitted a paper letter July 2nd, 2024, page 1, 2, 3, 4, 5, page 5 of the July 2nd letter. It says translated into approximately 9.5 million.
That is an approximate number. So if you want that's a calculation. So I don't have anything that would deviate from that submission to deem it inaccurate.
Okay. Why did UVMMC apply for this designation?
When we look at the type of population and location that not only we are, but also our patients that we serve, and we looked at what we might qualify for, and that does vary from periods of time. We did seek to ensure that we were receiving at all applicable types of reimbursement.
Great.
And do
when-
remember that we were coming off of FY 22 loss, and there were a lot of initiatives put forward. So we lost nearly 23 million in FY 23. So it's certainly a time for us to assess everything. And that's why you see so many initiatives around ensuring financial stability for the University of Vermont Medical Center, but also ensuring that for the patient population served for the state.
Great, and that relates back to what Dr. Eben and I were talking about, so that's helpful. So this evaluation of the Seoul Community Hospital status, it started when?
I do not have the exact dates in terms of the evaluation of that, but you know, we were granted that in December of 22.
And Ms. Peakley, you were the lead on that process?
Yes, with a group from our reimbursement team.
And were you the one that initiated the review of whether or not the medical center may qualify?
In conjunction with advice that we had received from some of our reviews, that we should look into that. Yes, we did initiate during that time.
Okay, sorry, what reviews?
So again, reviewing all of our reimbursement opportunities and strategies along with all of our expenses and revenue components.
And when did that reimbursement opportunity review occur?
I have the data. I do not have it in front of me in terms of when we began to have those discussions, but we can certainly look and provide a response on that.
That would be helpful. I'll flag that one for a follow-up. Directionally speaking, was it in fiscal year 22, 23?
In fiscal year 22, as we're assessing the financial outlook for fiscal year 22.
All right. And UVM's application was submitted on September 30th, 2022. Do I have that right?
I do not have the letter in front of me, but that should be referencing our letter date of submission. And we do have that can be validated if necessary, as well as the date in which we received approval.
Yeah, I think you received formal classification as a Seoul Community Hospital on February 1, 2023. Does that sound correct to you?
Anywhere between the December and February timeframe is when we were looking at approval dates. I would have to reference the exact letter.
Okay. Could we go to Exhibit 7, Kristen? Ms. Peakley, this is signed by you, dated December 1, 2022, sent to the National Government Services. Are you familiar with this document?
I am, thank you.
And the regulation under which UVM Medical Center applies 42 CFR 412.92. I think that should be the next exhibit. Do I have that right?
Yes, you're referencing that correctly.
Okay. And then could you specify what provisions UVM qualified under? I think I know the answer, but I want to make sure.
I think you have highlighted there, located within 35 miles from other like hospitals, is what you see that emphasizes our qualification.
Great. Okay, that's what I'd understood. Next exhibit. This is an exhibit from the letter that I referenced a couple slides ago. And here, the urban-rural classification, it indicates rural, and then you have an exhibit referencing the CMS approval. So you got the rural classification approved, and then you submitted this for the SCH designation. Is that right?
Correct.
Next slide, Kristen. And this is the letter from CMS to UVM Medical Center. about the application for reclassification from rural to urban, if you look at the ray line. And then the next slide, I believe, let me ask it, Ms. Peakley, is this from the UVM Medical Center application for sole community hospital status?
Yes, showing our qualification in meeting the 35-mile radius.
Okay. And so you look to, are you within 35 miles, number one, and then two is the hospital, if there is a hospital, is it a like hospital, correct?
Correct.
So you've got two hospitals within that radius. Then you go to the next slide. And you recognize this document from the application?
I did not prepare this document. I'm sure it is a required component of the application.
And correct me if I'm wrong, but this looks like it's going through an analysis to determine whether or not these two hospitals that were within 35-mile radius are like hospitals. Is that correct?
I do believe that is the intent.
Okay. And so you got Northwest, and then it compares the number of patient days and total patient days. There's a formula here, and you have to be. Can you explain this to me? Maybe that'll be easier.
We can provide follow-up information and in a response to you. I cannot today walk you through each of the lines. I do not have the detail document in front of me to walk through that, but happy to do that as part of a follow-up response.
Fair enough. Is my interpretation that this is an analysis of like hospitals? Is that fair?
It is stated to be a like hospital analysis, yes.
Is it fair to understand this to conclude that Northwestern was not, but Champlain Valley Physicians Hospital was a like hospital?
Based upon the document, it does appear that.
Okay. You may not know this, so I appreciate if it's a follow-up, but this for Northwestern goes through has years 2019, 20, and 21. As a follow-up, could you advise if Northwestern in prior years was a like hospital under this analysis?
I would have to look and see if we actually performed an analysis on prior periods.
And the next exhibit. This is also I'm sorry, go ahead.
And I do want to note that in terms of like hospital, it is a measure on not just do we look like, do we seem like we're like there is for Medicare purposes, are we a like hospital? So I do want to clarify that.
Right, that's what I understood.
Okay.
And then this is the travel distance, and it's represented, if you look, not the greatest quality. I did this 81 miles an hour and 40-minute drive. So this is, am I correct in reading this to be a representation of the actual travel time and distance to CVPH, which was a like hospital?
So Champlain Valley Physicians is on here, but there are factors in it. This truly comes from a internet map. You can see the source being Bing Maps, assuming light traffic. There are factors. So if you were to pull this again and it was high traffic, then the amount of time to travel there would be different.
But UVM submitted this document, or you don't know where I got this document, so that's not fair, but UVM submitted a document relating to the travel time to CMS as part of its submission, correct?
I would have to look at the submission again to understand all documents that were submitted.
Okay. So prior to fiscal year 22, we just talked about the various categories, or sorry, requirements to qualify. Were any of those different prior to fiscal year 22?
Could you restate the question?
We just talked about the requirements, the distance and the like hospital analysis. Were any of those criteria, would the answers of those criteria have been different in any prior years?
I am unfamiliar with prior years' criteria, so I cannot answer that fully. We would have to look in historically and see if any of the criteria had changed.
Do you have any sense, sitting here today, having worked on this submission, whether or not UVM Medical Center could have qualified as a sole community hospital prior to fiscal year 23?
I do not. I have not looked at that, nor the prior requirements for submission and qualifications.
Okay. So if the submissions and qualification requirements did not change from what I showed you, and the like hospital analysis and the travel distance analysis hadn't changed, is it fair to presume UVM could have qualified for that 7.1% Medicare bump in previous years?
One, I do not know if the status of any other like or not like hospitals would have changed during that time. So I think that is a complicated question in terms of we would have to look historically and do a historical look back to see if there was any level or ability to qualify historically. So at this time, I wouldn't be able to answer one definitively one way or another.
But there were only those two hospitals, right? In prior years within 35 miles?
To be honest, Chair Foster, I do not have the historical reference for the hospitals of Vermont prior to my arrival. So I would not be able to answer if there were more hospitals or fewer hospitals prior to this period in time in which you're reflecting, nor have I looked up any of the regulations or qualifications for that period.
So my concern is that UVM Medical Center could have qualified for this money for many, many, many years. So if you can follow up, could advise whether or not that's consistent with your understanding, I'd like to know that. And then for your board, I'm curious whether or not the board ever inquired whether or not UVM had money opportunities, significant financial opportunities from other classifications or from Medicare designations. Because over my read is that UVM Medical Center could have qualified for this money for many, many, many years. And if it's 10 million or so in this year, I don't know how much it was in 2011, but you're talking really significant money left off the table, on the table, and your budgeting is cost shift. And you had said that if you had gotten more money from Medicare, you'd charge commercial less. So I'm acutely concerned that we've cost shifted this money onto our really struggling commercial payers. And so I think it's really important that you look at this and analyze it. And I think it's important that your board ask itself what happened. And I know we can't fix the past, or maybe you can, maybe retro, I have no idea. But there needs to be accountability if there's significant dollars left on the table. And it goes back to the CMI project last year. We can't be making mistakes given our hospital cost structure on money from Medicare. Not now. I can't even tell you the letters and communications I'm getting from commercially insured Vermonters on the pain that they're suffering. And so if the medical center, our largest medical center, is leaving tens of millions of dollars on the table, it's a real problem and we got to fix it.
Thank you, Chair Foster. Certainly, that is something that must always be looked at. And I do have faith in the servants of this organization that there was never any intentional leaving of money on the table. We can certainly look at whether or not the organization qualified prior to the date in which we qualify for sole community hospital as submitted. We will certainly look into that. I do also want to speak quickly about the statement on the mistakes on CDI. I do want to clarify that there are not mistakes. There's opportunities for improvement in every hospital, every provider clinic in terms of documentation, because there are so many things that come in with a patient's needs that what we attempt to provide is kind of a top of mind thought process for our providers. And that is when they're seeing multiple patients, it's not always easy to remember, did I document this piece or that piece. So what we're doing is aiding them. And I don't want there to be a concept that we have been not properly documenting. We are using technology now to ensure that the patient's record is as complete as possible. So there's two components of that. Yes, can it more real time facilitate additional reimbursement to cover current costs? It can, but it also works to ensure the completeness of that patient's medical record for any provider who can see an Epic record. So that is a critical piece of it, not just a matter of the documentation on the revenue side of it. And there will always be improvement as regulations change, as CPT codes change, as the information comes, there will always be that on a continuous improvement opportunity.
Yeah, I appreciate that all very, very much. It's just that where we are in our affordability challenges, there's no money to be left on the table by not looking.
Agree.
Completely unacceptable at this stage. I can't even tell you how upset people are with the rates that we had to approve. And so it's not an excuse to say it was intentional or not intentional. I don't know the answer. I didn't study it. I read the reg. I read your submission. It looks to me like that's the case. I might be wrong. The CMI you acknowledged, but we are not in a position where there's money to be left on the table by mistake. I can't tell the people calling me, I'm sorry, they didn't mean to. We have to be better right now. And that's not to chastise you. The care board's got room for improvement. The state does. I'm looking at what we're doing, but we all need to be at the top of our game if we're going to serve patients, and leaving money on the table is not what we're doing right now. It's just wildly unacceptable.
So, and again,
and by the way, Rutland got its sole community hospital designation in 2009, and Dartmouth has had it forever. So like you should have been aware and been looking. And maybe you didn't qualify. I don't know. All
we
right,
will follow up with that response. Thank you for that. And as a regulator, it is certainly appropriate for you to ask these questions to ensure that we're doing our due diligence, ensuring that we are receiving appropriate reimbursement. So I certainly understand that. And I do just, again, want to say that in terms of case mix index and clinical documentation, that those are always performance improvement items that all organizations are looking at. And we will continue to focus on the care of our patients, how we deliver it, and ensuring that we are looking at opportunities to lessen that burden on commercial payers.
Thank you. And the Dr. Eppens pointing earlier, if there's opportunity that we see, if we see you're leaving money on the table, we will make sure we flag it. But
yes,
it's
please.
Honestly not our job. It's not anything our staff is assigned to do. We will absolutely make sure we do it if we catch it. But it's really the hospital and its executives and its board's responsibility to be doing that, not ours. We'll definitely flag it because I do not want to see commercial have to pay these rates. Let's take a 5-minute break, or actually 7, just because my computer is dying. I forgot to bring a charger. So why don't we take 7 minutes and come back at 12:20?
Thank you.
Chair Foster?
Right.
Chair Foster?
Yes.
What
Yes.
time were you thinking about for lunch?
Oh, how you guys doing?
Oh, I'm just wondering if you're going to, as you come back for 20 minutes and take lunch, why don't we just take lunch is what I was going to suggest. But I'm open to anything. People are planning a little bit because we've got to run out, grab food.
Why don't we take 5 minutes, come back at 12:18, and I'll try and wrap up in the next 45 minutes.
Thank you.
All right, thanks. So probably around 1:15-ish for lunch, somewhere around there, 1 to 1:20. All right, we'll take a quick break. Thanks. Dr. Eppen, are you back? All right, looks like Dr. Eppen and Ms. Peakley are back. We can continue on the record, Michelle. Could you go to the next document, Kristen, 14, please? This is some data I pulled from Adaptive on the UVM Medical Center net patient revenue, excluding fixed prospective payment for 21 to 23 approved to actuals. I just want to ask a couple questions about this. I'll try not to belabor it. So for fiscal year 21, on the net patient service revenue for commercial, the budgeted approval was $102 million more than actuals. Fiscal year 22 was $52 more approved than actuals. In 23, it was 18 million more approved than actuals. And then if you look at the Medicare amounts for fiscal year 21, the approved was 45 million less. The next year, Medicare was approved 20 million less. And the next year, fiscal year 23, Medicare was approved for 75 million less. And I was trying to understand why the approved amounts, the budgeted and then approved amounts, were so disparate from actuals.
I can certainly give you a overall kind of how we would get to that difference. I would then, if you needed more specifics as to whether it's inpatient, outpatient, we would have to pull that information and follow up with a response. Anytime, just like in our FY24 information, anytime you have a budgeted expectation, the utilization by patients can certainly vary. So there may be an expectation that utilization, like in FY22, utilization by Medicare patients was budgeted to be 306 million, and it came in actually at 328, stating that more services were delivered than originally budgeted, or a different type of service was delivered than originally budgeted in the gross roll-up numbers that you have there. So it really does depend upon, I'll just be what walks through our doors.
Yeah, right, understood. Why is it fairly largely under on commercial and fairly largely over on Medicare?
So during those periods of time, you'd have to do a deeper dive on what type of commercial plans were people using and were they delaying care because of, was there a COVID outbreak? Was there a flu outbreak? Was there anything that deterred them from care? Were they utilizing more high deductible plans? There's a multitude of why patients in any particular category may seek care more than usual in a year or may defer care.
21 and 22 were peak COVID years, and we were doing very little scheduled surgery. So I do wonder if that had an impact here, Chair Foster.
Oh, that's helpful. That could be. 23 is pretty wildly off though too for Medicare and Medicaid. 25% almost on both those.
Well, as Dr. Leffler, I'll let you speak to this. 23, we focused on access, opening up access and providing to deliver care at a pace that would meet or with demand. So Dr. Leffler, I believe you spoke to things that we were doing in 23 that carried to 24 as well as to 25. So we're seeing that access and the seeking of care both open up.
We'll have
Right,
to
I
look a
guess-
little deeper, but
Yeah.
my guess would be that 21 and 22, we saw less care delivered around scheduled care. In 23, we had a lot of pent-up demand across all payers, honestly, and we took what came in and what we needed to take care of to catch up. And there were a lot of older Vermonters who needed care in that year. And once again, we did a lot of targeted catch up on areas where we couldn't provide the care during the peak of the pandemic.
Okay. Okay. Any other thoughts you have on that as to, because I thought the access, it sounded like maybe some might disproportionately favor Medicare, Medicaid, like the dental that you gave, Dr. Leffler. But my question around this is really based on how reliable are your budget submissions? And these vary really wildly. And so it gives me concern that I shouldn't really be relying on the submission because it's just off. So any explanation you have is helpful on that.
So I'm going to give you a doctor's version of the budget, but then I want the experts to help. We start building our budget in February for this presentation. February, we're only less than half into our fiscal year, and we're making projections for more than a year out on some of the services we're going to provide, and what else is going to be going on. How bad is the flu season? What's the weather like in the summer? There's a million things that figure in. So the budget, at best, is a plan built by experts, but it's a projection of the future, and you never really know, in my opinion, what's going to come. Although really smart people the number of hours that go into building our budget is unbelievable, but it's a plan for more than a year in the future. And in healthcare, a year is a really long time.
No,
I'll
I get that. I can move on. I appreciate that. And it's something I've sort of thought about is how can these budgets possibly be really that accurate of a reflection? But from a regulatory perspective, it's twofold. It's one, your experience and what your needs and all that are, but then two, protecting the payers, the commercial insurance companies, and the patients. Let's move on.
If you don't mind, Chair Foster, I would like to just add a little bit, just because I think the key thing to look at at these numbers as well is that the total net patient revenue is in the ballpark. I mean, it's 5%. What was really different is between those payers. And with 2021 and 22 coming out of the pandemic, it took a bit of time for things to stabilize. The other thing that is in the mix here, we also had Medicaid redeterminations that we didn't quite know what impact that was going to have. So there's a lot of, in this particular time frame, there's a lot of moving parts that hopefully going forward, even though we do have to start early in the year, things have become a little bit more predictable moving forward.
Okay, thank you. That was helpful. Next slide, please. This is just some information from the audited financials for 23 and 22 for the network and subsidiaries. Next slide. And this relates to the med school and the financing of the med school through the medical center. And I just want to understand a couple things. I should have put in some arrows. I apologize I didn't. But if you go to, there's a commitment payment. There is, what is there? There's a commitment payment, an academic support payment, a dean's tax, and then there's an additional dean's tax. And the commitment payments in 22 on here is 59.6 million, and 23 it's 77.5 million. I think if memory serves, it was around 45 million in 21. What are these amounts for the commitment payment based on?
So the commitment, so any faculty that we have at the UVM Health Network, they have dual appointments. So they're employed by the medical group, and they're also employed by the University of Vermont. Being employed by the University of Vermont, they have to have a minimum amount of salary at the University of Vermont. So there's a minimum there that has to be met. For that salary, I'm just going to use an example. Let's say somebody has a $30,000 salary at the University of Vermont. If that salary, if there's no research or other external funding that person is involved in, that commitment dollars is essentially UVM sending us a invoice for that cost because that physician is spending that time as clinical time. So it's appropriate that the academic health system pay for that time. So this is a function of the fact that we've got faculty that are employed by both entities. But the way to look at that, those numbers that you just referenced, that's payment for clinical time that they provided. It's just that it's on the UVM payroll.
Okay. Okay, so but the determining factor of how much is clinical time that needs to be paid is the amount they're getting paid by the university. And you said based on research or funding that they receive. So if they receive less, sorry, let's just leave it there. Is that correct?
So the amount of clinical funding or the amount of clinical salary is the combination of the salary that they have at the UVM Medical Group and this commitment piece from UVM. That those two components make up their total clinical effort.
And if the research that they're involved in or the funding that they get from the university decline, does the medical center pay more?
Well, first, they have to then provide more clinical effort if they're not getting more research funding. So that's the first part of the equation there. They have to increase their amount of either clinical effort or administrative effort. So no, we don't pay for unfunded clinical time when that happens.
I see. Great. Okay. What is it budgeted for fiscal year 25, this commitment payment?
I don't have that readily available, but we can send that to you and follow up unless Judy, you have it or.
I don't, I have to pull it. We can do it in a follow-up. Thank you.
And that payment, does it come straight from the University of Vermont Medical Center to the university, or does it go through the network or some other entity first?
It goes through the UVM Medical Center first.
Straight to the university.
Correct.
Christine, skip up to 18, please. So this is the consolidating balance sheet for the medical center obligated group. And under the, I'm sorry for the resolution, I got better resolution later, but for fiscal year end 23, there's this line that I blew up at the top, current assets. What is a current asset?
So the current assets, so that's just the heading that you see there. It's made up of cash, short-term investments, and the next line is blank, but it's any portion of assets that their use is limited or restricted.
What's the difference between a current asset and a long-term asset? What's the dividing line between those?
Long-term asset would be any property, plant, or equipment that you're using over a longer period of time.
Or is there any temporal aspect? Like I'd understood current assets were assets that were due or expected within a year. Is that right or wrong?
So in the short term, and sorry, this is like really hard to see, and it doesn't look like all the lines are there, Chair Foster. But if you look at, I'm looking to the left, so receivables from third parties, I think you're probably referencing, that would be something that's due within the current year.
Right. Okay. Yep. All right. And then there's this line, due from related parties, the one with the arrow at it that's kind of highlighted, says due from related parties. So those are assets due from other UVM Medical Center obligated group members to the University of Vermont Medical Center in that year, correct?
Correct.
Okay, so for fiscal year 23, the medical center had $87 million due to it.
Correct.
Okay. And then down below, it says due to related parties under this liability, the second blow up that I tried to do. There's one that says due, where I put the arrow, due to related parties. And so under the medical center, there's a dash, meaning 0. Under CVMC, it says 32. So am I correct in reading that CVMC owes to a related party $32 million?
That's correct.
And CVPH owes 60 million.
Correct.
And would that be within a year of the date of this balance statement or within a date of when?
So that's their current, that's the total cumulative balance that's owed.
As of September 30th, 2023.
Correct.
Okay. All right, then go to the next one, Kristen. Then this is the CVPH consolidating balance sheet. And we just saw in the last one that there is that $60 million number owed to related parties. And then on the CVPH consolidating balance sheet, it's also, again, has that 60 million number. So this is just showing that CVPH owes a related party $60 million.
Correct.
Okay. And where is CVPH on making that payment to the University of Vermont Medical Center?
So this is the balance as of, sorry, there was an echo, 23. And we can get you where the current balance stands today.
Is there a document that memorializes the payment terms?
So we have, these are transfers that we do internally. And just by the way, we have been sending to the Green Mountain Care Board the New York to Vermont funds flow document that's been highlighting the change. A piece of that report actually is this due from balance change with all the other related revenue that comes from New York and expenses that come from New York. So just to be clear, we have been providing this data for several years.
Yeah, I've seen that. Okay, so my question was like, are there contracts or how is this memorialized, this 60 million that's owed from CVPH to UVMMC?
So there's no contracts that memorialize that. That's part of us as we function as a network. We will have balances that are due between the partners. There are many systems actually that don't even have this due from. So if you look at, and actually I think you even see it in some of the regulated entities that you have, when you look at their cash balance, it's 0 because all the cash has been managed centrally within their network structure. For us, again, we haven't created that consolidation, even though the rating agencies look at us on a consolidated basis. They look at our total days cash on hand for the entire UVM Health network. They look at our debt. We're still maintaining this level of essentially keeping the balances separate because we haven't made that change yet.
Okay. So are there terms? Is there like a term sheet? How do you know when they owe what money? Is there like a schedule of when they have to pay you back? Is there an interest rate?
Again, we're a health network. So we're one entity in terms of how we manage the funds flow between the organization. So charging each other interest for and having a term sheet when we're all part of the same organization is not something that it's not something you see in any network, and certainly it's not something we would do internally within the UVM Health network.
And what was this $60 million given to CVPH from UVMMC for?
So we can get you the detail behind that, but a piece of it, I assume is their share of administrative shared services, the physicians that work at CVPH, but we can provide you with a more detailed breakdown of that balance.
So you're paying CVPH money for their physicians working at UVMMC or providing shared services to others in the network.
So we're not paying them, but they owe the UVM Medical Center. Again, this is all internal transfers. In most other networks, you wouldn't even see this type of transfer happening. And so we don't view it as owing individual partners or paying them for providing the services. We need to continue to track these internally, but we manage our resources. We manage the resources centrally.
Okay, so to determine the amount that your UVMMC is going to give to CVPH, are there documents where these calculations are made? How much shared service they owe you for? Sorry, it's the other way. How many physicians were working, how much time? What's the process to actually make these calculations to come to this amount of money?
So we do have documents that that back up this amount. And to be clear, that this isn't the UVM Medical Center giving CVPH or other partners money. It's money that's owed to the UVM Medical Center. But we do have detail on how this is calculated.
Okay, right. So the distinction you're drawing is that UVM Medical Center provided certain services to CVPH, and the value of those services is $60 million.
Correct.
Chair Foster,
that's-
but I think, and Rick, correct me, but these are things like the allocated cost for my salary that CVPH needs to give back to UVMMC because of the way that we don't have that. Is that correct, Rick, or is it different?
That's correct.
Yeah, so it's because of the way that we pay out, and then we allocate the cost back to all of the organizations, and then they have to pay that back. And then there's other transfers that are occurring because perhaps, we had a doc go over there or vice versa, but all of those costs for us center out of University of Vermont Medical Center, but then get reallocated back. That's part of the issue with our Medicare cost report and the way that you look at it if you don't look at it completely. But all of those then come back. I mean, it's sort of get allocated back and then they get reconciled at the end. I'm just wondering if there's another analogy that would make sense, but it's just the way that I think of the different departments. If I'm running a hospital, if I'm Steve Leffler, sometimes the anesthesia services cost me more money than they bring in, and surgical services bring in more money than they cost me. But at the end of the day, I look at it as the whole because I've got to take care of that whole patient. And sometimes that means that I've got to move the patient to home health and hospice, which is within the network, or move them to Porter or vice versa. And all of those are just, we're keeping track of those in a way of a level of detail that it's a do to, do from. At the end of the day, we manage our entire network. And that's what really matters, right?
I think maybe to maybe highlight another point that may be getting lost in this is when you think about that $60 million, just to be clear, when you look at the financial statements for the organization, they have that cost reflected in their financial statements, meaning you look at the cost that they're paying for physicians, you look at the cost that they're paying for administrative services, that's in their profit and loss statement. How this shows up is essentially when you look at the cash balances between the entities, that's where you see the difference. Just to make that crystal clear, we're talking about cash balances and not the recording of expenses in one organization or another.
Right. Okay. Got it. They owe this money to UVM Medical Center because UVM Medical Center provided them services, anesthesiologist, Sunny, whatever it may be. Do I have that right? Ms.
Go ahead,
Peakley?
Judy.
So what we're referencing here is kind of the cash component. So the way the cash is flowing. So CVPH recognizes every expense that they have within their own P&L. And that's what drives their P&L, their profit and loss statement, their margin. Same with UVMMC. We're not reflecting costs on our P&L or in our budget that belong to another network entity. But there may be times when the cash itself gets funded from UVMMC's bank account, and that's what creates the due to. But it is not having an impact on what we're putting through in terms of our budget, the rate requirement, the costs. It doesn't have an impact on the P&L because those are appropriately stated on each individual partner's financial statements.
All right. Let's skip ahead. Kristen, would you go to slide 27, please? So this is a screenshot of the fiscal year 23 budget order from the Care Board. If you go to A, it says that the UVM Medical Center's fiscal year 23 NPR is approved at a growth rate of 10%. And then B says UVM's overall average, quote, UVMMC's overall average charge increase is approved at not more than 10.1% over current approved levels. And UVMMC's commercial effective rate increase is approved at not more than 14.77% over current approved levels. And I guess this might be for Miss, is it Champney? I don't know titles, president, vice president of negotiations with insurance companies.
Yes, Chair Foster.
I'm sorry, is it Champney? What's
It's Champney.
Champney? Great. And just so I have it, so I don't, what is your title?
Vice President of Managed Care Contracting for UVM Health Network.
These may be for you. What does commercial effective rate mean to you?
So the commercial effective rate we negotiate with our payers is the aggregate rate that you, the Green Mountain Care Board, approves. And that in totality of our inpatient, outpatient, and professional services, aggregate up to that approved rate.
Does that mean the amount of price increase you can give to an insurance company goes up by that amount, or does that mean the dollar amount can go up by that amount?
It's the percentage rate increase or change in price goes up.
Okay. And then how do you distinguish that in your understanding from the charge increase that's referenced in that same provision?
We have, sorry, my screen is blurring on that. So the charge increase, we have charge masters, as have been referenced, and charge masters charges can go up at times differently than the actual rate you approve. And so those are differentiated.
Got it. Okay. And then when you negotiate with insurance companies, and let's say you have this, I'm going to make it up. I'm going to make it an easy number, a 5% rate or price increase for commercial. Do you apply that cap of 5% across the board to every insurance company, i.e. no individual insurance company pays more than a 5% increase?
Yes, we negotiate based on your approved rate and we apply that across all commercial payers.
Okay. So one commercial payer isn't paying 7% and another one 3%. Is that right?
Due to the highly regulated nature, we keep it at the rate that you approve.
For each insurance company individually?
Correct.
Okay. And has that always been the case?
I have been doing this for 3 years, so I can speak to my experience. Yes.
Okay. All right. And then within that rate increase, we'll use my hypothetical 5% instead of the 14. There's any, do you do it by, do you negotiate by different CPT codes and procedures get different amounts than 5%?
Yes, that can happen, and that will vary by payer given the different reimbursement terms by payer.
And that's something you negotiate with each payer? individually?
Yes, a very detailed, not only negotiation, but analytics review and modeling.
Right, okay. And so I'm going to take a really simple example, say MRI with contrast, MRI without contrast. You could you could negotiate 10% on one, 0% on another, right? That kind of thing happens?
Hypothetically, yes.
Okay. And then you do the modeling to make sure that when it's all done in the aggregate together, it's under the cap of the care board.
Correct.
Okay. And simple examples help me, but let's say with my example, it was a 5% increase without contrast, and you project 100 for each. And if you do 5 and 5, the effective commercial rate increase is 5%, right?
Correct.
Now, if you put 10% on with and 0% on without, and you ended up having 200 with, the rate would be 10% as opposed to 5%, correct?
That could happen.
Okay. What is the process after you negotiate to monitor to make sure that the forecasting and modeling you did in negotiation bears out?
So what we have done is we agree with our payers on the terms, and then it is typically in the next year's negotiations. That base is now part of our Green Mountain Care Board ask, and so would be considered. But with payers, we agree in detail through Q4 this year, implement it with agreed upon terms based on the base that normally the payers provide. And that's how we monitor. And then we do evaluate collection rates as we've shown in prior slides, and how the payers perform. Are our rates coming in at the collection rate expected, which is actually how we monitor payer performance.
So I just want to make sure I get this. This is a little complicated for me.
Mhm.
After you negotiate, am I understanding this correctly that the monitoring happens the next year when you go to negotiate the new rates? You look back to see if the forecasting you've done was correct?
After we negotiate with payers, and there are slight variances with payers, so I am doing at the aggregate and totality of our negotiations. We're not going back code by code. We look back at how our budget performed when we're creating this budget and then coming up with a commercial increase from there. There is not a global budget or a reconciliation process with our payers on rates. If we do implement incorrectly, we do work with our payers to correct those, but there is not an aggregate reconciliation. That's not the way our budgets, or excuse me, our contracts are written.
Okay. So do you have a process to check to make sure that the rate ended up being at or below the Green Mountain Care Board's approval?
That's typically not part of our current process. What we do look at is where our payers are performing. And I'll give you an example, because we could do the unit cost increase, as you said. And then as payers put in different policies that we have no control over, we don't then go reconcile for those. It's really in the next year's budget, just like insurance companies are using their prior year's claims to predict their rates. We're using our budget experience to then move forward and say where we would need to go to update. So for example, if you're 10% with contrast happened, right? There was 200 there. That would be then the base for next year's, and we would see that. And so that's how we've done it historically with our payers.
I see. Okay. Kristen, next slide. We received this recent communication from Blue Cross and then a response from UVM on this concern about potential overcharges, and we're still reviewing that, and we'll get back to you on the right process to look at this. But I flagged this footnote because it jumped out at me, and essentially the footnote says that the commercial rate increase for CVMC in 22 is 6%, but UVM asked for 7%. Do you know if that's accurate?
I actually don't know what they're referencing there. I will say when we start negotiations with payers, we go on what our Green Mountain Care Board ask is, because that's the budget we need. So I can say that.
sorry, you go off that. So you ask us one thing. Sometimes we say yes, sometimes we say less. Do you
And
start your negotiations on your ask or the budget approval?
we go out because our negotiations include a number of things, not just the rate, but administrative policy changes. And we go out, this is our budget ask, because that's what we need. But then it is modified based on your final order.
To your knowledge, has UVMMC or any of its hospitals asked for a rate increase above the care board cap?
On our initial letters, yes. To my knowledge.
Why would you ask for more?
We have gone out with our letters prior to, our letters to payers are actually out the door right now. So it's in anticipation. So it's because these negotiations take a lot of time and modeling, we put out what, we've gone to budgets with.
Okay. All right, thank you.
But
I'm going to
Chair
shift.
Foster, I just want to be really clear. But then when the budget order comes back, Kelly or the team go back and say, well, we had initially modeled it at X. Now we need to model it back at what the rate cap is. And before it goes out and before anything's paid for the following year, all of that is settled. Just to be really clear.
No, I anticipated that. Yeah.
Yeah.
All right, I'm going to shift to quality. I don't know who the right witness would be to discuss quality. Who would that be?
Probably me, Steve.
Great. Next slide, Kristen. I apologize, I don't have the page reference, but this is from the narrative, and it discusses penalties from Medicare in fiscal year 24. Could you, Dr. Leffler, if you're the right person, describe what happened here?
So this penalty dates back to, I believe it's 22. It's actually related to that other slide you were showing. We were at the peak of the pandemic. We had lots of travelers. We had lost many long-term nurses. We had issues with getting people out of the hospital. So a HAC penalty is hospital-acquired conditions. So if you have more pressure ulcers or urinary tract infections, CMS can penalize you for that if it's above a certain amount. We have taken many steps since then to fix this, but it's historical. But we paid that penalty in 23. I think it started because it was from 21, and it's still in effect for 24.
Okay, let me make sure I got that. So the quality issues that were penalized by Medicare occurred in fiscal year 21.
This is pandemic timing, so we'll have to get to the exact year. I don't want to misquote. I don't want to say the wrong thing. This is historical. It's 21 and 22. There's a running average as they adjust this, and we're dealing with the pandemic years right now.
Okay. When you say dealing, you mean Medicare's penalties are relating to that period of time? Okay.
Yes.
And then it says in fiscal year 24, so the 21, 22 care, the financial penalty was applied in fiscal year 24.
Yes, they measure over that year and they apply it going forward after that until it's corrected, but there's a lag always.
Yeah. And does the University of Vermont Medical Center, do you have tracking of these same things internally that's going on contemporaneous, like more contemporaneous, I guess?
The number of pressure ulcers or UTIs, yes, every month.
Well, I'm not asking this very well. So hospital-acquired conditions, it can be a number of things. You report them to CMS at certain intervals. And my question is, but you actually have more current data than what you're reporting.
Yes, we report on their schedule, but we have regularly updated internal quality and safety data that we look at all the time.
Okay, great. Could you send that to us for fiscal years? I guess fiscal years. Oh yeah, fiscal years 22, 23, and 24. I want to see what these numbers that were penalized look like more recently.
Yes.
Had UVM Medical Center ever been penalized prior to this by Medicare?
I'm not certain.
No you have a long history, no recollection?
I've been in different roles at different times, so I do not recall being penalized, but that does not mean we weren't. I just may not have been in a position where I was aware of it.
And Dr. Leffler, from your, I don't know if you're how aware you are of the current data, but how is the medical center's hospital-acquired conditions faring today as opposed to 21, 22?
It's variable. We've had big improvements in some areas. I can tell you that, for example, we have 75 long-term boarders right now. Long-term boarders have increased falls, increased pressure ulcers because they're not supposed to be in the hospital. That really impacts this kind of data. So you have to put in nursing home type programs to help those people, but in an acute care hospital, that's expensive and hard to do, and the staff is trying to take care of sicker people. We have 25 boarders in our ED today. Many of them are not in hospital beds because we don't have enough hospital beds to put them all in or in the hallway. And so that can lead to pressure ulcer down the road, or that can lead to a fall if they're trying to get out of bed. So we work on this constantly. We have programs in place. We have goals for ourselves set. It's mixed.
Okay. Your answer is really helpful. There's no allocation, I don't imagine, but some of this can be due to a hospital